A very good afternoon to all of you. On behalf of the entire W4C Organization Committee, I welcome you to the World Conference on COVID and Critical Care. We are honored to have such esteemed faculty and speakers on board with us today. Our first session for the day is a debate on PP kits, whether a burden or help in COVID wards. I welcome Dr. Prashant Nasa, Head of Critical Care Medicine, NMC Specialty Hospital, Dubai, to chair this session. I now request our chairperson to introduce our speakers for and against the motion. Thank you, sir.
Thank you, organizing team. And we have a very interesting debate. I think one very important one, use of PP kits and how they have become a burden, especially while managing critical care. So we have two esteemed speakers for the debate. The first speaker is Dr. Sanjay Dhanuka, who is well-known intensivist and CEO at Eminent Hospital in Indore, MP, who is going for the motion. And he will be presenting why PP kits have become a burden. While against the motion, we have Dr. Sunil Karant, who is Chairman Critical Care Services at Manipal Hospital, and he is also adjunct professor in critical care medicine at Manipal University at India. So we should be starting with the session.
The volume is not there. Param, please play once again.
Strongly suggests that transmission from contaminated surfaces does not contribute substantially to new infections. Although inhalation of virus can cause infection, the relative contribution of inhalation of virus and deposition of virus on mucous membrane remain unquantified and will be difficult to establish as per the CDC. So what we need to follow the standard infection control procedures, which we always doing. Doing the appropriate procedures, we have to take precautions. So currently, multiple terms have been used for PP, which seem undefined, inconsistently used, and do not match PP to the modes of infection transmission. Let us see the mask, goggle, face shield. We use these things when we need to do for the procedures where the person is going to generate splashes, sprays of blood, body fluid, secretions, excretions, even the aerosol generating procedures in our ICU like bronchoscopy, suctioning of the respiratory tract, and endotracheal intubation. There we are already using all these things. The gloves we use because where we are getting scared of infected materials, mucous membranes, non-intact skin get contaminated of the patient's stool, urine, or even blood. So for prevention, we need a well-fitting mask, and as we need a soiled hands to be taken care by good hand hygiene and by environmental cleaning. So personal protective equipment should be simple to remove after use. There was an experience in Canada where it was used with a healthcare worker and it indicated that there was an increased risk of contamination during removal. So PP kit can be used for an appropriate procedure for a short duration of time. But if you wrap the whole body of every healthcare worker working in COVID ward for long shift, then yes, PP kits are definitely burden than help to the person. There was a survey in which it was found that 100% of the people who had responded, healthcare workers, they were soaked in their sweats, 100% of them. Then there was complaints of fogging of goggles, spectacles, face shields. 88% of people complained. Suffocation was a very big problem. Breathlessness was again there. The fatigue, headache due to prolonged use, pressure marks on the skin, then skin allergy because of the synthetic material, because there was no defined criteria for PPE kit material to be used. And again, impinging neck during intubation, all this slipperiness of shoe covers. So another survey in which many users again reported the same fatigue, dehydration, headache, they felt that they are wearing a rubber coat which hardly permits an air. There was some incidences of dizziness, lightheadedness, and fainting also. Those who had worked with PPE kit in hot atmospheres or in the extremes of heat like in India. Then there were some Italian nurses who had complained that they had a lot of face masks and this fall asleep while during working for long duration with PPE kit. Again, the healthcare worker who are using for long duration PPE, they have to retain their urine. They had not taken water. They experienced thirst and they develop problems like AKI, UTI, etc. So many infection prevention and control recommendations are based on minimal or no research studies or RCTs, instead relying on observational data, quality improvements, projects, and indirect evidences. There was a Cochrane review of evidence relating to PPE and protection of healthcare staff exposed to contaminated body fluids illustrated that the lack of robust evidence in this area. All interventions studied were supported by no more than one paper, and all evidence summaries were rated as very low evidence. So PPE is the least effective measure is that everyone is obsessed about. Even when used correctly, no form of PPE is 100% effective. Most PPE is relatively uncomfortable, which can result in inadvertent misuse and potentially cross-contamination, leading to an increased risk of exposure. So probably a patient feels that he is secure. A person who is using the PPE kit, he feels secure, but at the end of the day, he may infect himself because of using PPE kit continuously, and then at the time of removing the PPE kit, he may get infected. Again, there are persons who had a proper not fitted PPE kit, they are not taken it properly, the supply of PPE kit was not proper without sizes, and they had again made themselves risk because they were feeling that they had paid PPE kit and they are 100% secured. Then another health hazard of PPE kit that it was improperly disposed because of massive use of PPE kit in the hospitals. Then this was this photo picture itself revealed that the healthcare worker doesn't use this, and their misuse of PPE kit by others because of panic was there. And then a cartoon was published because of shortage of PPE kit. The people who were using doesn't know what is PPE kit, and the person who knows was not using it. So at the end, I can say that the PPE kit can be burden because if you wear yourself and completely wrap yourself, you should know that whether you are able to work comfortably or not. And that is what. So in conclusion, the PPE is the least effective measure. We need to follow standard precautions as per procedures required, but we need the best effective measures. So have faith on best answer available vaccine. Thank you.
Thank you, Thank you, Dr. Sanjay. I think that was a very, very interesting take on a very hotted topic.
Actually, for a lag.
So have faith on best answer available vaccine. Thank you.
Thank you, Dr. Sanjay. I think that was a very, very interesting take on a very hotted topic, very hot topic, which is part of debate, especially after the second wave. And now I invite Dr. Sunil Karant, who is a very senior intensivist and also head of the department at Manipal Hospital, Bangalore. So he will be speaking against the motion for the PP debate. I invite Dr. Sunil. Dr. Sunil, I think you need to unmute your mic. Unmute your mic.
Okay, now can you hear me?
We can hear you now.
Right. Thank you, Dr. Prashant and Dr. Sanjay. Thank you for your topic on the use of PP kits in COVID-19. Is it a burden more than a help? So that's the topic. So I'll be talking against, which is the con part of it. So in other words, should we use PP kits or not? Is this simple sort of equation or simple message from this topic? Please don't use PP. It is a burden on healthcare workers. And this is what my good friend, Dr. Sanjay Dhanuka has actually said. Let me start with a little bit of English. What is the meaning of burden? It is typically a load. Could be a heavy one, we agree, especially when we are talking about using PP in pandemic times. But I'd like to ask one important question. What is the value of human life? Is it more than the burden? We are all humans, aren't we? Every human life is worth the same and worth saving, is what Rowling said, and a lot of other people agree upon that. So if you compare the burden versus value of human life, I think I would accept a little amount of burden, because saving every human life is the goal of our profession as healthcare workers. Now, coming to the burden of COVID-19 healthcare workers, a lot of studies have shown that starting especially very early on in the first phase of, or the first wave, there were quite a few healthcare workers who were caught off guards, they were infected. In the first Cheney study, they documented over 3,300 confirmed cases of infected healthcare workers with a mortality of anywhere between 20 to 30%. In the US, as high as 19% of patients who in the first wave were identified to be healthcare workers. And by May of last year, which was in the peak of the first wave in this pandemic, about 13 reported deaths were there, which is 8th May, nearly 1.5 years ago this was. And the WHO estimated that a year later, that was in May 2021, there were over 110,000 or 115,000 healthcare workers documented to have died in the pandemic. And I'm using my words very carefully. This is official documented numbers. I'm pretty sure if you see a lot of studies, many more healthcare workers might have either died because of an unidentified disease or might have gone unrecognized. In India itself, we know that about 4.5 lakh deaths have occurred till now. So if in that context, if you look at comparing the Nguyen et al. In their initial study on which got published in the Lancet, they found that the risk of a healthcare worker getting infected had a 11.61 hazards ratio of getting infected as compared to the general population, which means 11-fold higher risk for a healthcare worker as compared to a community person or anybody who is in the community. Another good study which showed by Bandyopadhyay et al. Revealed that 37.2% of healthcare workers who were infected and who were above the age of 70 had a mortality of over 37%, which means that the healthcare workers seem to be more prone to develop the infection. They seem to be more at risk of mortality, of course, expected. I think this is sufficient enough evidence for my friend to understand that PPE is the way forward. I don't think even if there is a burden with PPE, we need to use PPE as healthcare professional. Of course, I'm sure Dr. Sanjay will ask for more evidence. Now, the same Cochrane study that he quoted, it's a very long paper, a very well done Cochrane analysis. And I think Dr. Sanjay picked up what favored him the most. The final conclusion of the authors was that there was low to very low certainty evidence based on a single exposure simulation studies that covering more parts of the body gives better protection, but comes with more difficult process of donning and doffing and lesser comfort for the user. So what it means, even in simulation studies, it is difficult, it is a burden, we agree, but the protection keeps increasing as we compound or as we get more and more parts of the body covered, which means there is no compromise for a full PPE. Even if you take the variable bias that was noted in this analysis, you find that the extent of high risk bias seem to be quite small in most of the studies, and many of them have low risk bias. So therefore, it seems to be a reasonably good paper. Of course, in the lack of evidence with very strong, good quality RCTs, we can only say that this is probably the best quality evidence that we have. In another study, which was published in the Infection and Chemotherapy Journal, it was found that with 90% compliance of PPE in the first 2 months of the pandemic, about 49 patients, they took about 120 blood samples, and they found that by the end of 2 weeks, each healthcare worker giving about 2 or 3 samples, they found that not a single person got infected, provided they followed the protocol of donning and doffing, and provided they ensured that there was good compliance of PPE. Now, coming to another meta-analysis, if you look at this meta-analysis of different viral infections or different pandemics, SARS, predominantly MERS, and a few studies involving COVID, you find that use of face mask seems to be favored, seems to decrease the risk of multiple events of infection or getting reinfection. So also the use of face masks, which is much more better, like the N95 respirator, as compared to a 3-ply surgical mask. You find that the forest plot shows a much stronger evidence in favor of using of N95 as compared to a little lesser favor when you use a triple layer mask. But all in all, use of a face mask is useful. So also use of a goggle in multiple studies on meta-analysis shows that it seems to be in favor of good eye protection. So as it has already been shown in the simulation study Cochrane analysis, you find that more the cover you offer, better is the protection. Use of personal protective equipment in the Wuhan pandemic, they found that this is the second part of the study. In the first part, they found, which was published in the WHO China Commission document, they found that about 17 to 22% of patients or healthcare workers were actually infected. However, when the precautions were ramped up, which was in the second or third month, which came up in the month of March, April 2020, out of 420 healthcare workers who managed severely sick COVID-19 patients, none of them seem to have got infected. And this was pitted against control healthcare workers who are not exposed to COVID-19, and they found that there was the extent of seroconversion or seropositivity seemed to be almost the same. So the yellow dots are the exposed healthcare workers or frontline workers, and the navy blue ones are the non-exposed ones. So prior to use of appropriate PPE, as I said, there were 2 studies which showed, one is the WHO China joint mission, which published that about 3,387 medical professionals were infected. Another single center study showed that out of 138 patients, 29% were healthcare workers. So the study which I showed previously was a month or 2 later, when the Chinese population or the Chinese healthcare professionals were much more better prepared. So I think if you compare the 2 kind of a before-after analysis, you find that use of PPE definitely helps in almost zeroing the risk of infection for healthcare workers. Hope my friend agrees. These are enough reasons to prove him wrong. And of course, this is another one. Stability of SARS-CoV on critical personnel protective equipment. You find that the SARS-CoV virus can stay active and infective for about 21 days if appropriate protocols are not followed. So I think giving reasons that you have a burden to wear PPE as a healthcare worker. I know I will sweat. I will have so many other problems. I think is just an excuse. Let us have genuine sort of evidence for it. I'll take up a couple of my friends' problems that he addressed. Difficulties encountered with PPE kits is there. We are not denying that. And at the same study that by Ankur Agarwal et al., which Dr. Dhanuka alluded to, there was minor problems, fogging, there was sweating, suffocation, agreed. But I think it is a small trade-off to save somebody's life. There's a similar blog by the NIOSH group by the CDC, which was written by Williams et al., also showed the same kind of physiological problems faced by the healthcare workers. The efficacy of PPE, of course, is also dependent on a number of other interventions as well. So it's not that only PPE is the end-all of all problems, as Dr. Dhanuka mentioned, that you need to make sure that other precautions also are in place, but PPE is a very, very important cog in this whole problem. So I think I would ask Sanjay to go ahead and defend himself if he still has anything to talk about.
Thank you, Dr. Sunil. I think that was a very interesting take on this very topic, which is very close to me, also being an infection control profession. So I invite Dr. Sanjay again to have 2 minutes of rebuttal before we conclude this session.
So thank you, Dr. Sunil. As you mentioned that the PPE kit and the importance of PPE kit, but always I had not defended the mask. I had myself presented that the mask is so I had told that the appropriate use of mask and the appropriate use of PPE kit at the time of procedure when it is needed. So debate is not on that, whether you use mask or not, whether the healthcare worker has been exposed and they had got died or they had exposed to these and they got diseases. The debate is on that, whether you wrap a person completely with the PPE kit in which he cannot breathe, he is sweating and he is working in a ward where only patients of COVID-19 were there lying in the bed. So the question is that whether you need only simple face mask. So majority of your studies, whatever has been there, they shows that the mask is I am also using mask, and I will not say that don't use mask. Every healthcare worker because there was no documented evidence that whether you use mask and you don't use mask and it is better. So I don't say that don't use mask, but giving a PPE kit, that's what I presented in my slide, that PPE kit has been misnomer in this COVID-19 and everyone was wrapped. And the PPE kit we were using for years in the OT, doing your procedures, we are using our gowns, but wrapping yourself in the kit where you can't breathe, you can't take proper water, you can't satisfy your thirst, and you are perspiring, you are exhausted, getting dizziness, syncope. I don't think that is needed, and none of your trials or studies or review says that the PPE kit complete in a ward where there is no exposure to the splash or the secretions and the mask has been taken care. I don't think that the PPE kit completely is useful.
So Dr. Sanjay, I would kindly beg to differ. I think as I showed in the simulation analysis and in a couple of other large meta-analysis, that greater the protection, greater is the greater the number of parts which are covered or the components that are used, better is the protection. Having said that, what I was predominantly referring to was COVID-19 patients who are critically ill. And I think there is probably no alternative to a PPE. Of course, there are problems of burden, etc., which can be addressed by probably having more frequent breaks, improving the behavioral therapy or the behavior of the healthcare worker so that they get appropriate breaks for nature breaks, drinking water, etc. So in some of the better centers, actually there are much shorter PPE breaks. They actually take off every 2 to 4 hours, which is probably a more appropriate way of doing it rather than, as you rightly said, keeping it for very, very prolonged periods, because you need to balance the risk versus the fatigue that would set in the healthcare worker.
So for the sake of the time, we will stop here. And I think both of you have raised up a very, very important issue. Being an infection control head of the unit and being a senior intensivist. So I'm seeing the both aspects, and especially with the receding waves, the things, get much more heated, whether to continue using the same sort of precautions. When we see the waves are there, the debate is less, but when the waves are receding, the debate is higher, whether we need to continue the same precautions. And the most important part is, this virus is way different from an influenza. We really know about that. There is enough evidence that the virus aerosolizes, and the major burden of the disease or the major transmission is through the aerosolization of the virus rather than through droplet one. And I think that where, healthcare is not just to be vigilant in terms of HVAC, which is a very important aspect, especially the indoor environment, besides the PP. And I think one point which Dr. Sanjay also wanted to say that, we need to differentiate use of a facial protection, which is much more important while dealing with an aerosolized virus, using of a N95 mask and a facial protection versus the other component of the PP. So, the evidence is still not enough to support the other components of the PP, but yes, there is a way proven evidence that N95 is something which has to be considered whenever you are managing a patient. Also, it depends upon whether you are dealing with a seriously ill patient versus a non-seriously ill patient. So the chances of having aerosolization is much more with a seriously ill patient. The other, important aspect which we also should be, working on, the breathing part of that PP. We know that these are important, but the issue is majorly because of the burden of the the layers of the cloth which we need to wear, especially with the humid and hot environment which we deal with, especially in the Indian setup. So I think the breathability is something which scientists should be working on. Maybe it's something which most of the researchers in the future should be look upon. I think with this pandemic, there are a lot of research which has happened, and this could be one of the area of a topic, using of PAPR and more of sustainable and breathable PPs, which can help us not for this ongoing pandemic, maybe in the future other respiratory pandemics where it will be important. So as long as we are fully protected, I think that is the way a healthcare worker feels when he is entering into ICU, that he is reassured that while dealing with the patient, he can be giving the same care which should be given to any other patient. So I think that's an important aspect. So at present, we can say N95 mask with enough face shield or a goggle is something which is a core component which should not be compromised. The other layer of clothes is something which need to be considered, but yes, the evidence is plus and minus. We need to look upon that part. But being a person from an infection control background, we should not play on these precautions as long as we have enough evidence to refute it. We do not have enough evidence to prove that they protect, but at the same time, there is no enough evidence to refute the other way around, that they do not protect. So at present, we should encourage our staff to wear up. We should do the things like what Dr. Sunil said, giving more frequent breaks, maybe giving them an option of breathable devices if available at certain places like PAPR. Yeah. At present, we should continue to follow all precautions. And I think that's the takeaway message from this debate. I thank you both, Dr. Sanjay and Dr. Sunil.
Just to add on, rightly, as you said, appropriate engineering controls and the right donning doffing protocols.
I think that's what
coming out of the debate, rightly, as Dr. Sanjay said, the process of donning and doffing is extremely important when there are more and more, layers of PP or protective equipment you're going to put. So that's another important point that needs to be taken home if you're really going to protect yourself well.
I thank you both. I think we are agreeing on these common points. So at the end of the debate, we all agree that these are the important components, and I think we should encourage our staff, but also make their life comfortable wherever it's possible. Thank you. Thanks a lot.
Thank you. Thank you, Dr. Sanjay. Thank you, Dr. Prashant.
Rohit, we can stop.
Thank you, speakers, for a very comprehensive and interesting debate. We now move on to the first thematic session for the day, where we will be discussing various complications associated with COVID. To chair this session, I welcome Dr. Bharat Bhushan, Assistant Professor, Department of Emergency Medicine, AIIMS Rishikesh, Dr. Amit Kumar Mandal, Director, Pulmonary Sleep and Critical Care Department, Fortis Hospital, Mohali. Dr. Yatin Mehta, Consultant Pulmonary and Critical Care Medicine, Fellow in Interventional Pulmonology, SRMS IMS Bareilly, and Dr. Sharmili Sinha, Senior Consultant Critical Care Medicine, Apollo Hospitals, Bhubaneswar. I request Dr. Bharat Bhushan to please introduce our first speaker for the session.
Good afternoon, everyone. Thanks, Dr. Rungta and team W4C for giving me this opportunity to speak on this very pertinent topic of neurological presentations of COVID, our own experience. So coronavirus has been found to have neuroinvasive capabilities and can spread from respiratory tract to the central nervous system. And mechanisms of neuroinvasion have been multiple, can be transferred across synapses from infected neurons, can be entry via the olfactory nerves, and transfer via vascular endothelium or white cells traversing the blood-brain barrier. So if we classify this, it can be classified from neurological features of viral infections, post-infective neurological complications, and infections in patients with neurological comorbidities. So in our experience till date, pre and post-vaccination, we've had 26 cases of stroke, 5 cases of encephalopathy in the pre-vaccination times, 1 case of GBS after getting the first dose of Covishield, acute ischemic stroke occurring after vaccination, although direct relationship is hard to discern. However, there was no direct evidence to link these occurrences solely as virus or vaccine-associated neurological complications. So severe inflammatory response and hyperthrombotic state in COVID-19 increases the likelihood of stroke. Additionally, vascular endothelial infections and damage to the vessels also increase the risk of ischemic and hemorrhagic infarcts. Stroke development is often associated with mortality. Mortality rate was found to be higher in COVID-19 stroke patients, with 38% indicating a worse prognosis in this group of patients. Though the number of males were higher than females, no differentiation by age was evident. Patients with cerebrovascular events were not only significantly older than those without CVEs, but also were more likely to have pre-existing vascular risk factors. This observation is particularly relevant in the Indian scenario, because vascular risk factors are common in the population, and so is the incidence of stroke. We have received and managed 26 cases of acute ischemic stroke who were detected to be COVID positive after initial screening when admitted to the emergency department. So we also published the practice implications of acute ischemic stroke during the COVID-19 pandemic for the Indian scenario, realistic and achievable recommendations through our Society of Neurocritical Care. And this is the clinical pathway where we had suggested how stroke should be handled when coming to ER. So taking a leaf out of our own experience, is a 42-year-old male, history of COVID, no comorbidities, found fallen from the bed with left-sided weakness and difficulty in speech, last seen normal at 11 p.m. on the 5th of the 9th. On admission, full GCS, upper motor neuron palsy on the left side, left hemiplegia, NIHS score of 7. CT brain showed subtle hypodensity in the right temporal cortex, CT perfusion mismatch in the right temporal cortex, insula, and gangliocapsulonic region, and corona radiata. CT angio and neck was done. Right MCA M1 segment occlusion, echo normal, ECG normal, Holter normal. Mechanical recanalization of the right MCA was done through solitaire stent. Post-stenting, patient showed improvement in power and speech. Subsequent MR showed acute to subacute change in the right insular cortex, periinsular temporal regions, putamen and caudate nucleus, as you can see in this diagram. in this MRI. Following thrombectomy, patient managed conservatively with antiplatelet statins and discharged home on the 11th. So as on the April 3rd, 2021, Ministry of Health had reported 0.6 per million cases of stroke as compared to the UK regulators of 4 cases per million reported. So it's a minuscule but definitive risk, although literature suggests that the risk is almost 70% less in persons from South and Southeast Asian origins. So CNS demyelinations have been documented following coronavirus as well. Another example from one of our cases, 46-year-old, history of COVID pneumonia, anosmia, quite pathognomic, irritability, increased sleepiness, right-sided weakness, admitted to a hospital in Raipur where CSF and MRI were done. The CSF was more or less normal. MRI reports showed multiple diffuse T2 hyperintense cerebral lesions suggestive of ADEM. Procal was 6.6. IVIG and prednisolone was instituted there for 5 days. Thereafter, the patient was shifted to us. Initial examination, right-sided hemiparesis, MRI brain contrast showed round-shaped lesions, cerebral white matter with alternating concentric rings, which is there in this MRI. Quite evident demyelination, suggestive of monophasic demyelinating disease like ADEM. MRI whole spine screen was normal. EG was normal. Echo, normal findings. So in view of the history, IV methylprednisolone and 5 cycles of therapeutic plasma exchange were done. In view of deterioration of respiratory functions, patient was put on ventilatory support and tracheostomy was done. Repeat MRI showed interval increase in size of the previous lesion and conglomeration and mild mass effect. As there was no improvement in the clinical status, IV methylprednisolone was given again. Post-stabilization and weaning, the patient was shifted back to the ward and later on to the hometown with a GCS of E4M4 with a tracheostomy in situ. Another complication which we have encountered is acute necrotizing encephalopathy. Poetji reported the first case of acute hemorrhagic necrotizing encephalopathy in a female airline worker in late 50s. The characteristic features included symmetrical multifocal lesions with variable thalamic involvement. As we see in this MRI, there's thalamic involvement. MRI images in the T2 B and F images show hyperintensity within the bilateral medial temporal lobe and the thalami. GBS, again, 16 cases of GBS after COVID have been published. Though temporal association with occurrence of GBS was seen in many reports, the evidence of direct invasion of nerves or nerve roots is unclear. In such cases where follow-up duration may be short, acute onset chronic inflammatory demyelinating polyneuropathy should be considered among the differential diagnoses. Treatment with immunoglobulins, plasma exchange may help in better recovery. It's ominous because of 2 reasons: because of chance of inadvertent exposure to the infectious virus in neurology wards, both for attending healthcare workers as well as other patients. And GBS is a disorder known to rapidly affect respiratory muscles, particularly if bulbar involvement sets in, which can cause sudden, poorly explained worsening of patient status if diagnosis of COVID has not been already established. So another example here, a 70-year-old male, known hypertensive, diabetic, COVID pneumonia in the last week of April, treated with steroids and oxygen. So this is something which we all have seen very, very commonly presented with left eye pain, watery discharge, and headache. On examination, left lateral rectal palsy, all relevant investigations keeping in mind fungal sinusitis, mucormycosis, or aspergillosis were done. MRI PNS contrasts evidence of fungal sinusitis with edematous left lateral rectus and intracranial extension. Endoscopic debridement of the sinuses, orbital decompression, and frontal cranial debridement was done. Thereafter, retrobulbar amphotericin B along with IV liposomal amphotericin B was instituted. Patient was subsequently discharged on the 19th. Patient went home well, So although a rare disease, it has been reported an increasing number of patients with COVID-19, especially in our country, caused by fungus mucor, capable of reaching craniofacial compartments such as paranasal sinuses, pharynx, orbit, and intracranial cavity via the spore spread. Invasion is highly lethal and rapidly progressive. Presents as diverse signs and symptoms including nasal stuffiness, mucoid or purulent bloody or black nasal discharge, epistaxis, facial nasal or periocular edema and discoloration, speaking defects, visual impairments, and excruciating headaches. Predisposing factors, obviously, we are the diabetic capital of the world, diabetes mellitus. Despite medical and surgical treatment, mortality is very, very high. Therefore, clinical guidelines should be in place for appropriate use of antifungals and antibiotics, and a multidisciplinary approach is essential to successfully manage these kind of patients. Data is insufficient at this point of time to conclude if neurology patients are more predisposed to acquire COVID infections. Patients with pre-existing neurological disorders may have a disease spectrum that may put them at a greater risk of acquiring COVID infections though. Age more than 65, comorbid lung disease, diabetes, renal disease on dialysis, receiving immunosuppression are obviously at high risk of severe disease. So I think I have covered the aspects of COVID. I would not like to go into the vaccine and vaccine related complications because it is beyond the scope of this presentation. With this, I thank you all for giving me this opportunity and wish the organizers a wonderful conference. Thank you.
Thank you, sir. I now request Dr. Amit Kumar Mandal to introduce our second speaker for the session.
Yeah, good afternoon. Thank you everybody for the wonderful opportunity. And Dr. Anurag Govil, I believe he's a GI physician. I think the slide didn't come up on the in the list. But anyway, I think he's going to be talking to us on the GI manifestation. We've had many manifestations. Presently, he's the clinical director and head Santokba Institute at Jaipur, Rajasthan. So without ado, Dr. Anurag, welcome on us. Thank you.
Hello and good afternoon from India. Job assigned to me today is to discuss GI manifestations of COVID. And for this, I must thank Dr. Rungta and also the Critical Care Society for having given me this opportunity to be part of such an important international symposium. Now, before we go any further, and try and understand the GI manifestations, let me first explain how the virus gains entry into the GI tract. As we all know, the virus needs ACE2 receptors to attach to cells. And luckily for the virus, ACE2 receptors are highly expressed in the enterocytes. And not just there, they're also found in the oropharyngeal mucosa. They're highly expressed in the biliary epithelium and endothelium. Luckily for us, of course, they are scantily expressed in the hepatocytes and sinusoids. What is also known is, and definitely documented, that there is replication of the virus in the intestinal epithelium. And this could partly be responsible for causing the symptoms. Now, whenever you have virus inside the intestine, obviously is going to appear in the stool. And once it appears in the stool, there is this theoretical possibility of fecal-oral transmission. It remains a theoretical possibility today, for it actually awaits documentation. But what is well known is that there is definite evidence of presence of the virus in stool. The highest positivity is seen in the first week of the illness. Patients with diarrhea is expected to have a high fecal load of the virus. 20%, and it's interesting to see that 20% continue to excrete the virus in the stool despite clearance from the respiratory passages. And because there is virus in the stool, a very strict disinfection protocol of the feces and sewage needs to be practiced. Coming to the symptomatology is largely very general. Up to 80% can have GI symptoms, which are predominantly nausea, vomiting, diarrhea, and abdominal pain. There's this very recent meta-analysis in Lancet, only 2021. It includes 35 studies. And it sums up to say that there's a pooled prevalence of GI symptoms in 15%. Again, pretty interesting that about 10% of these have only GI symptoms and no respiratory symptoms. And therefore, it results in delayed diagnosis. And such patients have shown delayed viral clearance. Now, at the peak of COVID times, it's easy to suspect, every patient coming is suspected COVID. But now when COVID is receding, one will really need a very, very high index of suspicion to diagnose COVID in patients presenting with diarrhea. Does it cause disease elsewhere? And sure it does. Pancreatic islets have ACE2 receptors, and therefore it can cause pancreatitis due to direct cytotoxic viral involvement. However, what is thought is that it is probably related to a severe systemic disease and multi-organ dysfunction, and less probably because of the direct cytotoxicity. The management guidelines are similar to pancreatitis of any other etiology, and luckily the point prevalence is pretty low. Other significant involvement includes acute cholecystitis because gallbladder epithelium also exhibits ACE2 receptors. Ischemic gut needs to be remembered and needs attention. It has been conclusively demonstrated and is not surprising because of the thrombotic dysfunction. We have ourselves had a very severe gut ischemia patient resulting in perforation, finally getting operated due to COVID. Other GI emergencies and GI bleed I will not be discussing for want of time because the protocols, they actually form a totally different topic to discuss. IBD and COVID needs a little attention, and the reason is that both, I think, the doctors and also the patients have some apprehension as to what to do with immune suppression during the COVID times. Luckily, the mortality rate is not unduly increased. What is known is that the prior use of steroid, prior use means prior to infection and prior to development of cytokine storm, and that remains a cause of concern, because such patients have shown a high risk of adverse outcome. And therefore, though not a very strong recommendation, but what is suggested is that using monotherapy with biologicals rather than the conventional combination therapy of steroids and AZA probably is a better choice, because the biologicals, of course, help in ulcerative colitis or Crohn's, but also have antiviral effects. Coming to COVID and the liver, now here I will very briefly discuss disease in a normal liver. We will not be discussing disease in an already diseased liver, which is cirrhosis or chronic hepatitis, as I believe that's again a separate topic in the same symposia. So the illness to the liver can come from all directions. It could be a direct cytopathic effect. It could be drug-induced injury, the systemic inflammatory reaction that of course causes direct cytopathic effects. There could be hypoxia, ischemia, and then reperfusion, leading to liver injury. However, when we see on the autopsy, there are not many autopsy series available, but whatever is available in the report in the world literature reports a wide range of liver injury in form of microvascular steatosis, inflammation, both lobular and portal, sinusoidal thrombosis, again as expected. What is interesting is that the virus positivity by PCR has been demonstrated in 55% of these samples. Rarely, the liver biopsy gives and shows evidence of cholangiopathy. However, clinically, the nature of injury is luckily mild, and by and large, it can be seen up to 80-85%, and by and large, it is only elevated transaminases. However, eliminated alkaline phosphatase in GGT has also been reported. More severe the COVID, higher the enzymes. Rare cases of acute severe hepatitis have been reported. If we have to predict which patients will have higher transaminases, then it is older age group, male gender, high BMI, uncontrolled diabetes, medications which can harm the liver, and also very high inflammatory markers in form of IL-6 and ferritin. AASLD has given a very simple approach to patients with transaminases, high transaminases. So if you have COVID and high transaminases, we just do a counter check on other viruses, namely A, B, E, and C. If they are negative, we need to just wait and observe. If the enzymes are stable, we do nothing. However, if they continue to increase, that's when you need to evaluate for other causes like myositis, liver ischemia, for cytokine release syndrome, and also remember drug-induced liver injury. And if it is so, remove those drugs. A liver biopsy or imaging elsewhere, like in form of ultrasound, these usually don't help. Could there be other features associated with the liver? Sure, there can be. Cholestatic features have been encountered. Secondary sclerosing cholangitis and cholangiopathy has also been reported. Acute portal vein thrombosis has been reported. An interesting thing is liver failure, secondary to herpes simplex in a COVID patient who was on Tacili and steroid has also been reported. Pediatric age group, again, luckily shows milder injury than the adults. So when coming to treat these patients, this is largely a symptomatic treatment. But are there some suggestions? Yes, there are. In patients with diarrhea, especially the ones with non-responding diarrhea, we need to remember and withdraw drugs which can cause diarrhea, especially the antivirals and antimalarials. Resicadrotil is an obvious better choice compared to the antimotility agents. Probiotics also have some role to play as there is ample microbiota change. Some word of caution, especially when it comes to nausea, antiemetics should preferably be used only with caution as they can prolong QTC interval and more so in the presence of other drugs like chloroquine, hydroxychloroquine, and azithromycin. Further word of caution includes PPI. I mentioned maybe avoid PPI, and I'll tell you why. There is presently concern regarding both aspects. One is increased risk of COVID in patients who are using PPI and increased risk of secondary infections in COVID positive patients. But what is interesting is the studies to the contrary are also available, and they're case control studies where there has been no increased risk. So there is some gray zone cloud over the use of PPI. But what is clearly known is that famotidine is associated with a low risk of clinical deterioration. The theoretical background is that it inhibits the COVID-3 chymotrypsin-like protease. So that suppresses the virus. And there are actually observational studies which have shown that there is low risk of clinical deterioration and even intubation in patients who are on famotidine. Indeed, a recent study combined H1 and H2, that is cetirizine and famotidine, and showed clinical benefits due to hampering with the cytokine storm. So if I have to overall suggest, there is some evidence to say that famotidine may be a better choice than PPI. Now, the discussion is not complete if I don't say a word on what happens post-COVID, where up to 15% continue to come to our OPDs with GI symptoms, and they're largely anorexia, nausea, reflux, distension, belching, and very ill-localized vague pain in the abdomen. And very interestingly, these patients are the ones who actually had a less severe COVID. These symptoms can actually persist up to 6 months, but they hardly ever require any evaluation and more than symptomatic care. Thank you so much. And if there are any questions, I'll be very happy to take.
Thank you, sir. One of our chairpersons, Dr. Yatin Mehta, has a question for you, sir. Dr. Yatin.
I am audible? Good afternoon, sir. I am audible.
You're audible, sir.
Sir, in swab negative patients, nasopharyngeal swab negative patients, is fecal sampling fruitful for diagnosis of COVID or not?
Sir, Dr. Anurag Govil is not available in the Zoom right now for the questions.
Yeah, can I just make a comment on that question, Dr. Yatin? I think stool sampling has not been standardized for detection of RT-PCR. There have been a lot of experiments and lab studies, but any particular CT values or values have not been validated in fecal samples for diagnosis of COVID positive cases as a screening tool.
But in few articles,
it is there. It can be detected, but as a routine screening and diagnosis, it has not been approved. Can be definitely diagnosed as we do for other RT-PCR studies on the stool samples as polymicrobial identification. It can be, but not approved for, as you said, for respiratory sample negative, but suspected for fecal samples. It's not been not a standardized one.
fine. Thank you. Thank you.
Thank you, ma'am. I now welcome our third chairperson, Dr. Yatin Mehta, Consultant Pulmonary and Critical Care Medicine, SRMS IMS Bareilly, to introduce our third speaker for the session.
Good afternoon. Now I'll call on stage next host speaker, Dr. Vinay Singhal. He is an additional director and HOD, Department of Critical Care, Fortis Hospital, Ludhiana. He is going to deliver talk on AKI in COVID ICU management strategies.
Good morning, everyone. First of all, I'd like to thank the organizers for giving me this topic on acute kidney injury and how we manage in our ICU. So we had seen, all of us had seen, in fact, this COVID-19 for our last 1.5 years in our ICU. And we had seen so many cases from mild diseases to patients who are coming with the severe ARDS, multi-organ failure, and they died in our ICU. We all know that acute kidney injury is very common amongst critically ill patients with COVID-19, and it affects approximately 20 to 40% of the patients who are coming to ICU. AKI is considered as a marker for disease severity, and it's a factor for negative prognosis. So if your patient is getting affected, he is going into the acute kidney injury, so your prognosis is bad. Of these, approximately 20 to 30% of the patients, they may require renal replacement therapy or at some or other time. Before coming to the management of this acute kidney injury, COVID-19, we should also know how it affects our kidney. So there are various phases. Initially, when the phase of viremia is there, at that time, the direct viral effect can cause the collapsing glomerulopathy and endothelial damage. And also, because of COVID, there is a coagulopathy, complement activation, and inflammation. They all can involve kidneys also because of these effect. Patients may get if affected indirectly also. Once this viremia phase is over, you can have your patients who are whose kidneys are getting affected because of the poor fluid management. Your patient is on mechanical ventilation, and your patient is having getting affected because of the poor management of mechanical. Because we know the hemodynamics changes, they differ differently, and especially when high PPI is there, resuscitation maneuver are being there. So we have to manage our fluids, especially during the mechanical ventilation. Then uses of nephrotoxin. The nephrotoxins, we know we are using all sorts of drug in COVID, and some of these can be toxic to our kidneys. We all know about the organ crosstalk. So our kidneys can affect indirectly because of other organs are involved, like hepatorenal syndrome, cardiorenal syndrome, or pulmonary renal syndrome. So the effect of one organ can affect other organs also. So we have to be careful during these times also. At the same time, patients are usually presented with a fever or diarrhea. They can have secondary sepsis, and these patients can be behind fluid, and hypovolemia can cause acute tubular injury. So these are the various mechanisms that can affect our kidneys during COVID-19. There are also the different phases of acute kidney injury development and progression. So patients are there who are at risk. There can be subclinical patients, and then the acute kidney injury sets in, and then stage 1, 2, and 3 are there, depending upon your rise in creatinine and urine output criteria. So we can see, if we identify these patients early during at-risk stage or subclinical stages of acute kidney injury, then it is better to manage, and better chances of recovery are there. So if in case your patient is at risk, and how to identify these cases, you have 3 options. You can have a clinical risk scores. Your patient is having some pre-illness, like they are having diabetes or other organ illnesses are there. Then there are high risk of getting your patient into acute kidney injury along with COVID. If your patient is are in the subclinical stage, then these biomarkers can be helpful, like tissue inhibitors of metalloproteinases, that is TIM2, insulin-like growth factor binding protein, IGF-BP, and GAL. And GAL is your neutrophil gelatinase associated lipocalcin. So these biomarkers are largely being used more and more cases of your acute kidney injury or in ICUs that can predict the occurrence of acute kidney injury, and they can catch hold of your patients during the subclinical stages of acute kidney injury. So your kidney failure can be predicted if you are using these biomarkers. So we are on this background, we can come and can think of starting how do we manage our acute kidney injury in COVID-19 cases. There you can see that there is no specific treatment option. So we had used during viremia stage, we can see that there are various antiviral drugs being used, but I don't think they are still debatable, whatever antiviral drugs are there. But again, so beyond that, everything is your standard of care. So your care of strategy for the patients with COVID-19, ICUs remains largely supportive. So we have to see that we should do no harm to these patients rather than actually having some specific treatment options. Early recognition can be done by using use of biomarkers. We'll talk in the next slide about it. Implementation of CADICO supportive care guidelines, which are there, like avoidance of nephrotoxins, regular monitoring of serum creatinine and urine output, and consideration of hemodynamic monitoring. So, like in all the diseases, if early recognition is done, we can halt the disease progression. So, early recognition of kidney involvement in COVID-19 and use of preventive and therapeutic measures to limit subsequent acute kidney injury or progression to more severe diseases are crucial to reduce the mortality and morbidity. So, this is there for all the diseases, and that is there for acute kidney injury also. Now coming to the role of AKI biomarkers. Here you can see that many biomarkers are being used, like cystatin C, NGAL, TIM2, and more biomarkers are available in ICUs as point of care investigations. Currently, these biomarkers have been successful in identifying high-risk patients for clinical trials, investigating early prevention strategies. And combining these biomarkers along with the functional or clinical KDIGO criteria may allow better characterization of AKI. And to the extent now these policymakers, they are thinking of incorporation of these biomarkers in the AKI definition. Next in the line is the nephrotoxin stewardship. We had talked about the antibiotic stewardship for years together. We had talked about the fluid stewardship for years together. But you can see that drugs are estimated to be third to fifth leading cause of AKI in critically ill patients. We call it DAKI, drug-induced acute kidney injury. These drugs can be antibiotics. They can from any group of drug. And we had seen that so many drugs are being used in COVID-19 cases for the treatment or without knowing the exact benefit of these drugs. So we have to see that whenever we think that our patient is in the early stages of acute kidney injury or in the preclinical stages who are having very high chances of getting going into the acute kidney injury, we should stop or remove these drugs from our kidney. There is a need for nephrotoxin stewardship in hospitalized patients that includes the appropriate drug dosing and preventing and ameliorating adverse drug events, ensure kidney health by preventing and ameliorating the drug-induced acute kidney injuries, avoid unnecessary cost by choosing test and treatment wisely at the same time when we are doing all these things, and implement coordinated patient care management strategies efficiently. We have to regularly monitor our kidney functions. Measurement of kidney function is necessary for precise clinical assessment of risk and stage of acute kidney injury. The serum creatinine and urine output are current gold standard for the evaluating kidney functions, although neither is kidney specific or sensitive for detection of early kidney injury. Hemodynamic monitoring, very, very important. Whenever we see a patient who are coming with AKI or pre-AKI stages, the volume depletion sometimes is a very important factor because these patients present with a fever and pre-hospital fluid resuscitation is rarely performed. Balanced crystalloids should be the initial management for the expansion of intravascular volume in patients at the risk of AKI or with the AKI, unless a specific indication exists for use of some other fluid. Strategies should also aim to avoid unnecessary overloading of these patients and reduce the risk of pulmonary edema, right ventricular overload, and congestion. Whenever we ventilate these patients, sometimes these very high PEEP and recruitment maneuvers are being done on ventilator for post-COVID ARDS, and this can further compromise the volume status of the patient. Fluid and vasopressor resuscitation using dynamic assessment of cardiovascular status may reduce the risk of renal injury and respiratory failure. So these patients may require renal replacement therapy at some or other time, and it should be definitely done, I feel, as early as possible whenever clinical guidelines or clinical criteria suggest the need of renal replacement therapy. I don't know, it is again debatable, but again, early, how early is very early, and if we do late, then we may miss the bus. There is suggestions and consensus statement from ADQI work group, and that suggests that how to stage-based management of COVID-19 AKI can be done, and ultimately what suggests to conclude with this these remarks, that early recognition of AKI is important. Standard care should be done, it should be given to prevent and manage the MODS, and use of biomarkers to diagnose the AKI as early as possible, avoidance of nephrotoxins, regular monitoring of serum creatinine and urine output has to be done, and consideration of hemodynamic monitoring, advanced hemodynamic monitoring, to keep our patients in proper fluid balance is important to manage our AKI. Thank you very much.
Thank you, sir. I now request Dr. Sharmili Sinha, Senior Consultant, Critical Care Medicine, Apollo Hospitals, Bhubaneswar, to introduce our fourth speaker.
Yeah, good afternoon all. I take the pleasure in introducing Dr. Brahma Sharma. He is a senior faculty in Via Medical Center, University of Pittsburgh, United States of America, to speak on sudden cardiac deaths post-COVID as cardiologist dilemma. Over to you, Dr. Brahma.
Hi, good morning. This is Dr. Sharma from University of Pittsburgh. Appreciate the opportunity to speak to you, and especially thanks to my friend, Dr. Runta. My topic is post-COVID death, especially out of hospital death. And in a very short time, I'm going to present to you a summary of the data and mechanisms and how we can prevent it. Now, first time when we heard about this out of hospital death was actually New York Times in March 2020, when a lot of reports came out from the Wuhan in China and also Lombardy, Italy. But it was not until this front page news came in the New York Times that we found out that something is going on. Most of these people who came to hospitals were positive troponins, and they were taken to the cardiac cath lab, and it was not clear, is it a coronary is it a corona or coronary artery disease because of this COVID virus? And that's where the new science of COVIDology was born. And this was a deadly combination of the COVID and cardiovascular disease. And then the focus and attention was geared towards this lethal combination of pre-existing cardiovascular disease and COVID. Now, the whole spectrum of findings were observed at that time, and a new term was invented called acute myocardial injury. And this was different from usual STEMI and non-STEMI patients that we see, type 1 or type 2. And in addition to acute myocardial injury, there were a lot of other cardiac manifestations that were also concomitant with this pathology, which was new to us all over the world. We had a myocarditis, we had a stress cardiomyopathy. We also had people going into heart failure, and of course, concomitant arrhythmias. Some of them are fatal, including pericardial effusion, pulmonary thromboembolic disease because of the endotheliitis. Now, this is the first case report in Los Angeles about a lady who was at home and died suddenly, and it became the headline news as to what is happening, why this person is dying at home. And the news of this sudden death at home became the headline news all over the country in America. And of course, very soon, there were more frequently fire calls from the Houston, Texas, and we knew something was going on with the people with COVID at home. They were dying and more suddenly. And of course, the registries were set up in Lombardy, Italy, in 4 provinces, including Cremona, Puglia, and Matau. At the same time, there were subsequent registries, including one in France, one in New York, and of course, one in Sweden. The common finding in all these registries were that as the incidence of COVID went up, there were also more incidents of out-of-hospital cardiac death. And not only that, the survival was poor, obviously for multiple reasons, but this was a trend all over the world. At the same time, there was a there's Times of India report where it was very obvious that people went home after being treated for COVID. Nonetheless, as soon as they went home, they felt better, but they died at home. So this is a strange phenomenon of out-of-hospital death when they left hospital and apparently were recovering was a mystery to all of us. And some of the possible mechanisms were identified. Of course, myocarditis was one of them, but looks like that played a very small role. And of course, acute coronary syndrome, acute myocardial injury, but there was also very sinister phenomenon of thromboembolic disease, microthrombi and coronary arteries, cerebrovascular disease, and of course, the pulmonary embolism, in addition to other. But most common denominator or final common pathway of these entities was, of course, the fatal cardiac arrhythmias. These mechanisms were stratified into three categories: pre-existing, because of the COVID risk factors, and because of the environment. Ultimately, we have to zero in of the sudden death happening outside. And before we go into a little bit further, let me define the sudden death. It's very well defined. Any abrupt loss of consciousness within an hour of onset of symptoms in an individual with or without pre-existing heart disease. So we have to narrow down sudden death out of hospital in these people who went home and find out what was going on. Of course, ultimate cause of death is arrhythmia, not so much the atrial, but the ventricular arrhythmia. And it is well reported that some of these ventricular arrhythmias were not only VTAC, VFib, but mostly asystole or pulseless electrical activity. Some case reports of polymark VTAC was also observed. And it was strange that some of these people more likely to have non-shockable rhythm rather than shockable rhythm, and that led to the demise and poor outcomes. In addition to that, there were other important factors playing a role: hesitancy on the part of the people to start CPR, also late response, late treatment, and by the time they came to hospital, the outcomes were definitely worse. And of course, because of that, there was a new thinking about how to prevent this sudden death for people going home, and we had to define the natural history of these people. Of course, when they tested positive, they had a treatment, but later on, they continued to have this subacute and chronic phase, now very well known as long COVID syndrome or long haulers. And these people, when they left home, they had a fatigue, they had a dyspnea, they had a persistent EKG changes, some of them a headache and brain fog, but they were also at risk for some kind of acute myocardial injury as well as thromboembolic phenomenon. And keeping that in mind, there was a very nice study published in Nature from the Washington University School of Medicine, St. Louis, in a VA data, and it was very well defined that there's a post-COVID syndrome, and these people continue to be at risk for death at home. So they need to be monitored, the biomarkers need to be evaluated, their serial electrocardiograms and troponins need to monitor, including echocardiogram, and there has to be a team approach to these people who left hospitals. And the team approach would consist of a pulmonologist, cardiovascular specialist, hematologist, renal guy, and of course a psychologist or psychiatrist. So we can monitor these people very closely, not only daily examinations, but also 6-minute walk test, PFT, chest X-ray, markers, as well as high resolution CT scan to figure out early on before they have a sudden death. And because of that, we also have to make sure we are ready to institute the CPR depending on the patient and the site, of course, keeping the precautions in the mind. And with that emphasis, much more activity was done in terms of in-home CPR and only CPR, hence only CPR was also instituted with all the precautions. American Heart Association jumped on it and also publicized very widely all across the country that these people are dying home not because of intrinsic disease, but also because of environmental issues, public hesitancy, lack of response or delayed response, and combination of all the things were also compounded by the fact that some of these people did not receive care and did not reach in time in addition to other things. So there's multiple reasons why these people were dying at home. And so the whole new awareness was instituted and people were encouraged to go to the emergency rooms as well as seek attention so that they can be saved, not only in hospital, also at home. And question about the dilemma that I was also comment. Of course, there was a dilemma in the COVID epidemic right at the beginning, all along the pathway. When we learn more and more things in the beginning, of course, we were kind of in a dilemma in terms of diagnostic challenge. Is it a really acute coronary syndrome, STEMI, non-STEMI, or this is an acute myocardial injury from COVID? Of course, every time we try to take care of these patients, we're also in an ethical dilemma as to what is the risk to the patient and what is risk to the doctor, and balancing this risk was very crucial. Of course, there's also ethical dilemma in providing care to these people who came to the emergency room very, very sick. Do we let them go and have a compassionate care versus jumping on and have a heart team and going all the way providing them advanced therapies? And of course, the importance of shared decision, family decisions, and heart team. So at every level of this epidemic, right from the diagnosis to prognosis to therapy, there was a dilemma, and this is a new dilemma for doctors, new dilemma in this new epidemic. And I'll stop here. Thank you very much. If you have any questions, I'll be hanging around. If you have any questions, I'll be happy to answer. Thank you.
Thank you, Dr. Sharma, for a very insightful and precise presentations. I have a questions. Is Dr. Sharma with us?
No, ma'am.
Is not there at the moment. I think there has been just a comment that there has been a lot of questions both from the laymen and from doctors community regarding the continuation of heparin and antiplatelets, if at all, for patients with moderate to severe disease and those who have comorbidities like diabetes, hypertension, and as such, if they had any complications during their stay in the hospital. So this has remained debatable, but I think more or less it is consensus that there is no role of antiplatelets to give to these patients when they are being discharged from the healthcare centers. On varying occasions for variable kind of cohort of patients, however, the heparins have been continued after discharge up to a period of 2 to 3 weeks, depending on the setup and the clinician's judgment. So thank you, Dr. Sharma. And I have a question for Dr. Vinay Sehgal. Is he? Dr. Vinay Singhal, is he there? Dr. Vinay? On acute kidney injury? Yeah.
Yes.
It was nice listening to you, Dr. Vinay. Actually, just one quick questions on the COVID-related AKI.
Yes.
Sorry. Do you feel, I mean, according to in your experience and according to the literature, do you feel the prognosis of COVID-related AKI is different from non-COVID-related AKI, like most commonly sepsis-related AKIs?
Dr. Mili, actually, what we had seen, this recovery depends upon in what stage you are seeing the patient. Morning, we are listening to discussion on COVID by Dr. Deepak Govil and all in that scenario also. What we are seeing, why we are seeing more problem in our experience, as we are seeing cases very late at our centers. If cases comes early and we diagnose it early, then definitely the recovery chances are very good as in other sepsis-related acute kidney injury. But once your patient presentation is delayed, because most of the time what we are managing in COVID is oxygenation or oxygenation failure, your ventilation and oxygenation failure, we are just managing these things. And most of the centers are concentrated their efforts on managing these patients on these grounds only. And in here, what happens, they used to miss on this acute kidney part. And if you miss this acute kidney injury part, then it's very difficult for your kidney to, but your incidence of renal failure is not very high if you keep these things in mind from starting. And you manage these well, you give good amount of fluid, anticoagulation and all. If you start your therapies early, then I don't think we have any problem in recovery of the kidneys.
Right. Thank you, Dr. Vinay. Is Dr. Govil with us? Dr. Anurag Govil?
Yeah, can you hear me? Yeah, I'm very much here. Can you hear me?
Yes, sir. Yes, sir. You're audible.
I can't start my video because the host is...
No worries, sir. I
Yeah,
just
sure.
I had just wanted to seek your experience and comment on co-infections in cases of patients who had predominant GI manifestation of diarrhea associated with COVID?
Well, in our experience, we have had diarrhea which has responded to just nothing. And there is really no way to prove whether there is a concomitant viral infection associated with that. But we did not, at least in the patients that we have seen in our experience, pick up co-infections. These stool examinations in these patients have largely been normal, and cultures hardly ever that we've done have not shown organisms. So I think they were pure COVID-related diarrheas and not really co-infections. I hope I've answered your.
So there have been there have been some case reports actually. Interestingly, in the first wave, especially we found 4 patients at least where we did this GI panel on the stool sample, and because the presentation was quite confusing and the first samples were negative for COVID, the respiratory samples, of course. So when we did the RT-PCR on GI panel on the stool sample, they actually grew enteroinvasive E. coli 1. There was the enterotoxic E. coli 1 case. The 2 others were negative, and subsequently they also came positive for, I think, one of these E. coli variants. I do not remember. So, but later on, actually, they had started with developing chest respiratory manifest symptoms, and we found infiltrates, and they turned out to be RT-PCR positive for respiratory sample as well. So there have been some case reports, I think, which says that E. coli can be present, or enterohemorrhagic or enteroinvasive E. coli can be present, maybe just they're pre-existing or co-infections in these cases. That bit confuses sometimes.
Yeah, I agree totally. I mean, dual infections are difficult to prove and disprove both. So we've had patients who had stool positive PCR and no symptoms at all. And the reverse obviously can also be true, what you just suggested. So, but to have 2 organisms causing diarrhea at the same time and to prove the causality is not easy. So yes, I don't deny what you just mentioned, but we did not, at least in our experience, come across any co-infection whatsoever.
The only thing that would actually, in terms of therapy, would be relevant is about using the antibiotic like most.
Yeah, that's right. In fact, and not using azithromycin because that can give rise to diarrhea. That's true. But our patients with COVID diarrhea improve with nothing actually, no medication, just supportive care.
Right, sir. Thank you very much.
Thank you. Thank you.
I think if there are more questions, you can conclude this session. Dr. Anushka.
With this, I would like to take the program further to the second thematic session of World Conference on COVID and Critical Care. To chair the session today, we have Dr. Himanshu Yadav, cardiologist, Agra, Dr. Neeraj Tyagi, consultant, Sir Gangaram Hospital, New Delhi. We also have Dr. Raman Chatrat, consultant intensivist and anesthesiologist, ex-president ISCCM Amritsar. We have Dr. Simal Jha, MBBS diploma in anesthesiology, Nirvan Super Speciality Clinic, Delhi. I would like to request Dr. Himanshu Yadav to introduce our first speaker of this session.
Hello, friends. It gives me immense pleasure to be part of the World Conference on the COVID and the Critical Care. We fondly call it the W4C 2021. I'm now going to take you through the art of proning in COVID-19. I always like starting with a quote, and Max Lucado said, "A man who wants to lead the orchestra must turn his back on the crowd." And we as doctors, to orchestrate the victory of an ARDS COVID patient, must turn him prone at the right time to get him successfully out of danger. Proning a patient with ARDS has been long practiced in the ICU with improvement in oxygenation and mortality. This was demonstrated in the Proseva trial in NEJM in 2013, where noticeable improvement was shown when patients were proned for more than 16 hours. Since COVID-19 has been a disease predominantly affecting the lungs, causing the L and the H type of ARDS, proning has been very useful modality in the treatment of COVID. We must therefore understand that proning is a very useful maneuver across the entire spectrum of COVID-19 patients, right from its use as a COVID awake repositioning proning, fondly called the CARP protocol, in awake hypoxemic patients, those on oxygen therapy, those on high flow nasal cannula and non-invasive ventilation, those on invasive mechanical ventilation, and finally those on ECMO. The art of proning actually begins with an understanding of the science behind proning. So let's look at the science behind proning. How does proning improve physiology? And if we understand this, we would understand how proning improves the entire spectrum of oxygenation through the COVID patient in its journey through improvement. So it improves the optimization of the VQ mismatch, increases FRC, reduces atelectasis, facilitates secretion drainage. The abdomen is less likely to distend, less lung deformation. Heart does not press on the left lung, and therefore that decreases the atelectasis, decreased transpulmonary pressure gradient between the dependent and the non-dependent lungs in the prone position. It also improves the plateau pressures. Recruitment maneuvers have also shown improvement in the prone position, and so on and so forth. And these are very nice pictorial representations of how prone will work. And you can see in this diagram here that in the prone position, there is a good shaping and matching of the lung tissues. And here on the CT scan, once the patient is prone, within the first 10 minutes, and then after a while, after a few hours, you can see how much area of the lung can actually get rated. So tips to make proning successful are the next 10 steps that I'm going to take you through. The first is to develop a protocol and a checklist for proning, which would include gathering the supplies, designating roles, and taking care of lines and tubes, because we do not want a mishap to happen during proning. Second would be to ensure appropriate equipment is available, including as simple as flat sheets to pillows to ECG leads to be put on the back, long tubings, PPEs to protect yourselves, gel or foam face cushions should all be made available. Step number 3 is to identify the team that is going to prone the patient, define the roles and responsibilities. The team should consist of a nursing personnel, the respiratory technician, the physicians, etc. And key responsibility should be given for someone to look after the endotracheal tube, the lines, the central lines, etc. And also look after the monitoring of the cardiorespiratory status. Step number 4 is to clearly identify indications for proning and choose the right patient who should be prone. And we know from the previous definitions for proning is that the prone position should be considered in patients with ARDS with invasive mechanical ventilation and those who have refractory hypoxemia, which can be indicated by a PaO2 FiO2 ratio of less than 150. Or prone positioning may also be considered with posterior wounds, burns. Hello friends, it gives me immense pleasure to be part of the World Conference during proning. And a checklist for proning, which would include gathering the supplies, designating roles, and taking care of lines and tubes, because we do not want a mishap to happen during proning. Second would be to ensure appropriate equipment is available, including as simple as flat sheets, to pillows to ECG leads to be put on the back, long tubings, PPEs to protect yourselves, gel or foam face cushions should all be made available. Step number 3 is to identify the team that is going to prone the patient, define the roles and responsibilities. The team should consist of a nursing personnel, the respiratory technician, the physicians, etc. And key responsibility should be given for someone to look after the endotracheal tube, the lines, the central lines, etc. And also look after the monitoring of the cardiorespiratory status. Step number 4 is to clearly identify indications for proning and choose the right patient who should be prone. And we know from the previous definitions for proning is that the prone position should be considered in patients with ARDS, with invasive mechanical ventilation, and those who have refractory hypoxemia, which can be indicated by a PaO2-FiO2 ratio of less than 150. Or prone positioning may also be considered with posterior wounds, burns, and skin flaps if they are also associated with our COVID patient. And as you can see this wonderful diagram in which prone positioning is actually important depending upon the PF ratio, and all the other interventions are mentioned in this one diagram. Fifth is to clearly know which patients cannot be prone and why should not they be prone. So if you do not have your ICU staffed with trained personnel, do not venture into proning your patients. Increased intracranial pressure, abdominal and chest wounds, extreme obesity, hemodynamic instability, pregnancy, etc. would become relative and absolute contraindications. The next step is to identify a standard time to prone and also to unprone. So proning can be done as a daily routine. And for example, you might plan a timing of 2 p.m. and then the next morning as 8 a.m. and that would give you at least a 16-hour proning in your patient. Why these timings have been chosen is because these are the timings when the shift of the nursing changes. And that's the time when you have nurses from both the shifts, and therefore you might have more manpower. So both the shifts can actually incorporate an actual proning and unproning process. Seventh step is to modify care to mitigate any adverse events. And we have a checklist of preventing these. And the main important one here would be the pressure trauma, which could be again from head to toe. It could be to the eyes leading to blindness, orbital necrosis, bridge of the nose, the head of humerus, or the knees, the breast implants, the male genitals. Decreased enteral nutrition can also happen because of the position, difficulty in performing procedures or to reintubate if the tube has inadvertently come out, and if the patient has a cardiac arrest, it could be a double whammy and a big issue. So you need to have as simple things as pillows appropriately placed to try and improve the oxygenation, prevent the atelectasis, and also prevent the bed sores. So a technique which is so easy and well performed could have an all win-win situation. The next step now is to use simulation if you could. It could be a low fidelity simulation using mannequins. It could be an interdisciplinary team efforts and a proper communication between the team members, and team dynamics really would help in actually going through in your minds and in person the entire steps of proning and unproning. The 9th would be later to do a debriefing, a feedback and an audit. And 10 would be to plan for the special circumstances, that is those patients with COVID who would be having obesity, renal replacement therapy, and cardiopulmonary arrest due to hemodynamic instability. And these are the group of patients which need or who need special attention. Once we have decided whom to prone, whom to unprone, how long to prone, we need to know when to institute it. And we know, as I mentioned earlier, that proning can be instituted in a COVID-19 patient in a broad spectrum, right from A to Z. And therefore, awake proning, this was a very nice trial which actually showed that awake proning helped patients a lot. And this is the actual word for it. That is the CAP, that is COVID Awake Repositioning Proning Protocol. And first you put them prone, then you do a left lateral, then you ask them to sit up 60 to 90 degrees, and then you do a right lateral, and then do you a prone position. And this, the patient can do it themselves. Many of our patients who are on home oxygenation and those who are actually desaturating, if they themselves try the prone positioning, they would improve themselves in their oxygenation and the SpO2s would boom up the moment they would prone. So they keep the pulse ox on, and from as low as 88, it might even improve to a saturation of 95 with or without the oxygen. This could help in buying time before they actually reach the hospital. And this can be actually used not only in the awake person with or without oxygen, but also those on HFNCs and NIVs, along with the other ICU protocols, which would be the fast hug BID protocol. So as I said, proning can be used with nasal cannulas or nasal cannulas with non-rebreathing masks, or even NIV, or a Venturi mask, or an HFNC, or even after the patient is on an invasive mechanical ventilation. And there are various protocols which we should have in our ICU, and this is just one example of a proning guideline by the Penn University, and we should have our own protocols which we should devise depending upon the manpower and the facilities that we would have. So this is another diagram where a patient is proned along with the HFNC, and you can do the same with NIV as well, keeping a close watch on the work of breathing and the saturations. And simultaneously, you can also use it in ECMO patients and severe. This is a very important statement, where severe COVID-19 disease most often may lead to an atypical ARDS, requiring, in the most severe cases, a veno-venous ECMO. The management of persistent severe hypoxemia under veno-venous ECMO requires a multi-step clinical approach, including prone positioning. So there are do's and don'ts and key recommendations of what should be done for these patients who need ECMO and how they should be prone. So in summary, whenever we prone a patient, especially on mechanical ventilation, we need to look at the respiratory benefits of proning. We need to look at the circulatory benefits of proning by all the things that it can actually do, and then look at the 5 Ps. And if we follow the 5 Ps, we would be proning a patient very, very successfully and convert it into a proper art of proning. And that is prepare, plan, perform, protect, and then perfect the art of proning. So in summary, my friends, proning is a labor-intensive maneuver which helps improve oxygenation in a patient with COVID lung. It is useful across the entire spectrum of patients, from those who are self-ventilating right up to those who are on ECMO and mechanical ventilation therapy. Proning, if done in the right patient, by the right personnel, for the right duration, with the right planning and the right execution, can be the most effective way to improve the PF ratio, and the mortality in COVID ARDS patients can be reduced. We are too prone to engrave our trials in marble and write our blessings in sand. And I think we should give it a thought and look at the benefits of proning and convert the art of proning and the science of proning into a benchmark and a bedside way of helping our COVID-struck patients. Thank you.
Thank you, sir, for the enlightening talk. Now I request Dr. Neeraj Tyagi to introduce our next speaker.
Thank you, Dr. Kushra, for such a nice presentation. Now I invite Associate Professor from AIIMS Jodhpur, who will is in the Department of Physical Medicine and Rehabilitation. And our next speaker is Dr. Ravi Gaur. Over to you, Dr. Ravi Gaur.
Greetings to all. Myself, Dr. Ravi Gaur. I'm a physiatrist working in Department of Physical Medicine and Rehabilitation in All India Institute of Medical Sciences. This is the institute designated for as a COVID center for Western Rajasthan, and this is my department where I work. So today we are going to discuss about the chest physiotherapy during COVID patients. So what first most important is what is chest physiotherapy? Why pulmonary rehabilitation to be preferred over chest physiotherapy alone? The areas which we assess in a COVID patient in ICU for pulmonary rehabilitation, what are the prior requirements for chest physiotherapy, various techniques of chest physiotherapy, and how we remove the secretions after the chest physiotherapy. So first of all, chest physiotherapy is a airway clearance technique to drain the lungs, which includes various ways to dislodge thick secretions and mucus plugs clogging the tracheobronchial tree. It prevents retention of secretions as they obstruct airways. This retention of secretion augments infection, and if chronically persists, that can damage the airway by inflammatory cascades. So how the chest physiotherapy works? It assists in clearance of secretions by creating a shearing force along the airway walls. It also leads to sympathetic stimulation of cilia by catecholamine release and parasympathetic stimulation of airway mucus glands. Why pulmonary rehabilitation, not just physiotherapy? As we have seen that during this pandemic era, we have how much resources we have to always channelize our resources in a proper way. Otherwise, it will be an haphazard situation. So prioritizing the disease, selecting the severity of the patient, and requirement of any kind of treatment is very important in such cases. In an ongoing project in COVID-19 cases in Western Rajasthan, we found out that 67% cases have symptoms of dry cough, fatigue, and fever. And productive cough is the less common symptom, or in just 12 or 15% cases. Also, with the COVID pneumonia and acute hypoxemic non-hypercapnic respiratory failure, we found out that there are more chances of barotrauma. So using or prescribing chest physiotherapy becomes a tricky task, and as maneuvers utilized to do chest physiotherapy can further lead to injury to the lung. What are the basic concepts of rehabilitation in pulmonary setup? It's timely identification, assessment of the disease severity, clinical assessment of the patient, and plan according to that. Prior requirements of chest physiotherapy, we always keep in mind the safety of the self, surrounding, and patient, as this is an aerosol generating procedure and it's very high risk of exposure is there. Always assessment of vitals, basic nutrition, and neurological assessment of the patient for critically ill neuropathy and myopathy is very important. We have to look out for the invasive lines, catheters, tubes, and ICD, if any, in place. We have to localize the affected area of chest with proper chest examination and auscultation. Level of exhaustion of the respiratory muscles is also very important. We have to also look for the comorbidities which are increasing the severity of the disease. So what are the steps in chest physiotherapy? First of all, humidification and hydration. Then there is exercises. Here I would like to emphasize that chest physiotherapy is basically not an exercise. These are maneuvers which are planned to do any kind of help of the patient to expectorate his cough. So manual percussion techniques, which we usually see in the our routine ICU areas, and there is postural drainage, forced expiratory maneuvers, and mechanical aids. All these things are utilized for chest physiotherapy. So any person who is affected having a thick secretion or intubated or inhaling dry airs, he needs humidification, as nose itself is a natural humidifier. So in cases of thick secretions, intubated patients, babies with risk of airway blockage because of secretions, patients on oxygen therapy who are mouth breathing, NBM, or having dry mouth, using CPAP, all are having high flow dry gases, and those needs humidification. After humidification, these are the basic procedures which we try to implement to dislodge the mucus plugs and clear the airway. First of them is ACBT, it is active cycle of breathing techniques. Here, there is cycle of huffs with from mid to low lung volume interspersed with deep breathing and relaxed abdominal breathing. There are 3 steps in this case. First is relaxed tidal breathing phase. Then there will be thoracic expansion breathing phase, then followed by forced expiration phase of huffing and coughing. Another technique is segmental breathing, where we focus specific on the specific lung areas. As for apical lobes, apical breathing techniques are used. For middle lobes and lingula, lateral basal expansion is utilized. And for lower and posterior lobes, the posterior basal expansion technique is used. The other variety of this chest physiotherapy is autogenic drainage. Patient is instructed to breathe at different volumes, high, mid, and low lung volumes sequentially, followed by forced expiration techniques. Augmentation of this technique can be done with manual percussion techniques like shaking and vibration. This is the very important technique as it is more effective for peripheral airways. These are the basic techniques of manual percussion which we use to see in our ICU setups. Percussions, here you see rhythmic clapping of the chest with loose wrist and cupped hands, creating an energy wave that is transmitted to the airways. Vibration consists of fine oscillation of hands directed inwards against the chest, performed on exhalation after a deep inhalation. Shaking is a coarser movement than the vibration and in which the chest wall is rhythmically compressed. All 3 needs to be interspersed with relaxed deep breathing to prevent airway closure, desaturation, and bronchospasm. There are various contraindications like bone-related osteoporotic, metastatic, and fractures, loss of skin integrity, pain, recent excessive hemoptysis, clotting disorder, surgical emphysema, unstable angina, and arrhythmias, where we should avoid percussion and vibration. Postural drainage is another important thing. As we localize a single segment, we try to use gravity to assist drainage of the secretions of that particular lobe, but the exact mechanism is not clear about the same. Doing postural drainage in early morning helps clear the night accumulated secretions, and the postural drainage an hour before sleep reduces the night coughing. It should be avoided before the meals. For bronchodilators to be if any, we have to prescribe 15 minutes beforehand. These are the basic procedures, postures which have to be utilized for postural drainage. Every posture takes around 10 minutes of, say, in a particular segment to be drained out. We need the posture to be maintained for 10 minutes. In a single session, we don't use more than 3 sessions as the session should not expand more than 30 minutes. If any kind of discomfort is felt during the procedure, we should, like headache, discomfort, dizziness, palpitation, breathlessness, or fatigue, or hemodynamic instability, the procedure should be discontinued. And the most important position is alternate side lying position for generalized kind of secretion. Various contraindications for pulmonary this postural drainage is recent stroke, acute head injury, unstable hypertension, surgical emphysema, recent pneumonectomy, surgery to esophagus, cardiac sphincter of stomach, history of seizures, epistaxis, pulmonary edema, cardiovascular instability, bronchopleural fistula, and risk of aspiration. Now, once the cuff is being dislodged, now we have to take it out from the bronchial tree to trachea and trachea to the mouth. So most best evacuation technique is a strong cuff, which once the secretions are being loosened enough by other means of techniques. So to cuff, we use 2 techniques. One is huffing, the another one is cuffing. Huffing means you lean in both the techniques. The patient leans forward with the elbow slightly bent and inspire 2, 3 or 3, 4 tidal breaths, and then a deep inspiration is done, followed by breath holding for say 2-3 seconds. Then there is a full forceful exhalation, saying this is the mechanism by which you do huffing. The epiglottis is open in these cases, which leads to no increase in intrathoracic pressure, and patient there are less chances of getting a rupture due to this. This is best suited for removal of secretion which has already been dislodged till the central airways. The other method is cuffing. Here, everything is similar to huffing, but the glottis is closed. So there are increased chances of having a rupture after cuffing. So it is not continued for more than 5 to 6 times in a session, and it is more beneficial or efficient in cases of taking out secretions from the peripheral areas of the lung fields. When huffing and coughing are not very effective, then you have to add some mechanical devices like creating positive expiratory pressures. These devices use eddy currents and Tesla phenomena of the air, so that the pressure on the to create back pressure on the alveoli and the bronchial tree. So by this method, you prevent closure of the tracheobronchial tree, and loosened mucus plugs are recovered to the main line. Flutter is a device which is a short fat pipe and suited to anyone who can blow bubbles. The combined effect of positive expiratory pressure and oscillation are exploited by the flutter. For say upper lobes, you have to tilt backwards, and you have to for lower lobes you have to tilt forward to utilize flutter. Here, the maximum pressure is achieved is around 10 to 20 centimeters of water. Cornet is another design which is a flexible hose and acts like a valve. Here, the positive pressure and the oscillations can be created by actively breathing out through a curved plastic tube called a cornet. Fang et al. Claimed that this also decreases sputum viscosity. Acapella is the newest device and easily available in all the ICU nowadays. It combines the effect of PEP therapy with airway vibration to mobilize the pulmonary secretions, and can be used in any position, allowing patient to move freely and sit, stand, and recline. So, as per the person's capacity or reserve is tidal volume and reserves, there are high flow acapella and the low flow acapella, which are color coded. If in a high institute setups, we find that there are mechanical percussors and vibrators, there are inflatable waist as high frequency chest wall compressors. These devices create a cuff-like experience without allowing the patient to say produce cuff by himself. So in these cases, they generate 50 centimeter of water pressure at a frequency of 520 hertz delivered via pneumatic vest, which is surrounds the chest. These air pulses oscillate the chest and cause transient flow increase in airways, loosening mucus and producing cuff-like shear forces. Instructions to the patient is: inspire through the diaphragm, breathe slightly larger than the tidal volume, hold the breath for 2-3 seconds, exhale actively but not forcefully through the device. The exhalation should be 3-4 times longer than the inspiration. There are a total number of 10 to 20 PEP breaths have to be performed for after removal of the mouthpiece. Then we do 2-3 huffs to expectorate the secretions. For these devices, there is a contraindication of raised ICP more than 20 mmHg, high active sinusitis, middle ear pathology, or suspected tympanic membrane rupture, recent facial oral surgery or trauma, epistaxis, active hemoptysis, and esophageal surgery. So after discussion on all these points, I think the take-home messages we can have is chest physiotherapy is an excess secretion removal technique and not an exercise to be prescribed in each case. Dry cough, wheezing, bronchi are the main problem in cases of COVID in ICU and long COVID cases. Sometimes proper supportive humidification is the only thing needed. So proper examination is a must. Chest physiotherapy should always be interspersed with deep breathing relaxation to maintain the saturation. We should also ensure the COVID protocol safety measurements for all the patients in all the workers in the surroundings. We should not pressurize our therapists to perform chest physiotherapy if the patient is vitally unstable, as this can lead to barotrauma, ICTD displacement, or aspiration. In cases of loose or localized secretions, postural drainage become more important than the chest physiotherapy. Always discuss with ICU team and physiatrist wherever feasible before starting physiotherapy in COVID patients. advised exercise type in cases of COVID in ICU settings are mainly non-exhaustive ones for the maintenance of endurance only. So I would like to conclude after this. Thank you.
Thank you, sir.
One question I would like to ask Dr. Gaur. Good presentation, but you just tell me how effectively the physiotherapists were doing physiotherapy during COVID first wave and second wave. Just because of heavy transmission, because of fear of getting affected. I don't think so physiotherapist was that much involved. I don't know.
Good afternoon, sir. In our setup, we usually post one physiotherapist in ICU on a daily basis. And out of say 30 patients in AIMS Jodhpur in ICU setup, we usually say that first we assess all the cases. Then there are only 3 to 4 cases where we need to posturally train those patients, or selectively we have to enforce their this respiratory muscle strength, or take out the cuff. As most of the times we have seen that wherever there is a COVID, the affection or area affection is most peripheral areas are mostly affected, and almost each and every lobe is affected. So in those cases, mostly postural drainage we planned for removal of cuff.
I was asking just because even during intubation we are taking so much precautions, putting BiPAP so that there will be no spread of airway. But we want to contain the virus effect, and you are talking about this much physiotherapy that is possible during the normal time. If we do this much in that one COVID ICU and other things, practically speaking, is it possible?
Sir, that's why I initially said that an ICU and a physiatrist has to be combinedly putting their effect to identify those cases where it is utmost priority. I would like say the better word is triage. First you have to identify, then you will go on those high priority cases where you can get good results. Then you can plan physiotherapy, just physiotherapy specifically for those cases.
In our setup, PSRI, where I'm working in ICU, where our staffs who were well trained, they were doing mostly. Now, physiotherapists only in the very complicated cases when the advice was sought, they used to come.
Sir, in our setup, we have 8 to 9 physiotherapists.
That is a good thing. That is a good thing.
1 to ICU only.
Yeah, that is a good thing.
Thank you, sir.
Thank you, sir. Now I would like to request Dr. Raman Chatrath to please introduce our next speaker for the day.
Good evening, good afternoon, everybody. I'd just like to introduce Dr. Sai.
Post-COVID respiratory failure is the real threat right now as the number of new cases are going down. We know that 30% of people with SARS and MERS had persisting lung abnormalities after their acute illness. Even post-COVID-19 patients showed altered respiratory function after the infection. After recovery from the acute phase, some patients require evaluation and management for persistent symptoms or new onset symptoms. Even though it's a small proportion of patients who develop post-COVID lung fibrosis, considering the millions of COVID-19 cases, it's really worrisome. Symptoms of COVID-19 up to 4 weeks following the onset of illness is considered as acute COVID, while symptoms persisting beyond 4 weeks and which are not explained by an alternative diagnosis is considered post-COVID condition by CDC. Beyond 12 weeks is considered chronic. The persistent symptoms in patients after acute COVID-19 has been extensively studied. Fatigue has been the very important physical symptom post-COVID, seen in more than 70-80% of the people. Dyspnea is seen in more than 50% of the people. Chest pain, tightness, psychological and cognitive impairment are also seen in significant number of people. So now what are the issues concerning post-COVID respiratory failure? Organizing pneumonia post-COVID late pulmonary embolism, post-COVID lung fibrosis, even critical care neuromyopathy seen in especially people who have had prolonged ventilatory care. Cardiac manifestations like myocarditis, myocardial injury is also presented as respiratory failure in significant number. Secondary fungal and bacterial infections, especially aspergillosis, is well known. What are the risk factors which are contributing to the development of respiratory sequelae in COVID-19? Advanced age is one of the important risk factors. Increased disease severity, including comorbidities like hypertension, diabetes, obesity, ischemic heart disease, are all implicated. Prolonged ICU stay and duration of mechanical ventilation, especially when there will be a ventilator-induced lung injury seen in people who are mechanically ventilated. Again, smoking contributes to increased severity of COVID disease as well as subsequent sequelae in almost double the number of people. Alcohol abuse and dependence, it's been implicated in increasing the severity of COVID-19 disease. So how you evaluate these people initially? Chest X-ray has been typically done at 6 to 12 weeks. Early imaging is to be done when another etiology is suspected. HRCT is to be done in suspected interstitial lung disease. If chest pain, palpitation, dyspnea, and other cardiac symptoms are associated, go for an ECG, 2D echo, and occasionally 24 hours Holter in these cases. Pulmonary function tests are very useful. Maximal inspiratory and expiratory pressure defects are seen in suspected neuromuscular weaknesses. Spirometry, especially the lung volumes and diffusion capacity deficits, are seen and helps in knowing the etiology of or pathophysiology of respiratory failure. 6-minute walk test is a good screening test. To summarize this, whenever in the follow-up after 3 weeks, do a chest X-ray, ECG, blood count, CRP, and oxygen saturation. And when there is suspicion of COVID-19 lung damage, go for a dual source CT scan with contrast angiogram. So this helps to prove or rule out pulmonary embolism. At the same time, we'll pick up interstitial lung disease. So whenever there is signs of interstitial lung disease on CT, go for spirometry, gas diffusion test, and then in selected cases, lung biopsy may be needed. So if pulmonary embolism is confirmed, go for treatment of pulmonary embolism. So this is a usual protocol, but should not miss one of the treatable things like organizing pneumonia in post-COVID ARDS patients. So this has also been well documented that organizing pneumonia is generally sensitive to glucocorticoids. Now that glucocorticoids in a dose of 6 milligrams daily of dexamethasone or equivalent dose is recommended by WHO in moderate to severe COVID, it could decrease the incidence of organizing pneumonia on ARDS secondary to COVID-19. So this is the upper two images show organizing pneumonia in a case of COVID, and the images lower, they show clinical response to glucocorticoids, a good resolution with some fibrotic changes. So these things have to be picked up and then treated early. So these upper images show similar kind of organizing pneumonia, but when not treated with glucocorticoids, there is significant persisting lung damage seen after 4 weeks. COVID-associated pulmonary aspergillosis is another infective cause for post-COVID respiratory failure. So here again, we have known from our past SARS experience that there is definitive evidence of co-infection with other microorganisms in a subset of patients, including disseminated invasive aspergillus infection and cytomegalovirus infection. The prevalence goes up to 15% in one of the post-mortem cohort. Use of systemic corticosteroids was speculated to have contributed to some of these cases. And in critically ill COVID-19, it's been suggested that the prevalence of aspergillosis is as high as 25%. So we recommend that the clinician should have a high index of suspicion for bacterial and fungal co-infection and also use steroids very judiciously. A careful microbiological sampling and analysis are required to ensure that infective complications are picked up early and addressed as early as possible. Pulmonary embolism is another a late complication which can occur even after 3-4 weeks also, because we exactly don't know how long the hypercoagulable state lasts in a COVID patient. A procoagulative status is triggered by persistent inflammatory phase of infection. and they develop embolic episodes in spite of anticoagulation in some of these patients. So adequate antithrombotic therapy is necessary for prevention of acute and later thrombotic complications and pick up early and treat this pulmonary embolism adequately. Now, what proportion of these COVID-19 patients developed lung fibrosis? It's all speculation versus extrapolation because we don't have the hard data to prove this. Why they develop fibrosis? Because COVID-19 leads to intense cytokine storm. There is pneumonitis, there is ARDS, there is hyperoxia, there is ventilator-induced trauma, there is thromboembolism. So all this ultimately lead to aberrant repair and pulmonary fibrosis. So there are radiological findings which have been extensively studied in this, but we don't have the long-term data for COVID. But in SARS patients, we know that at least 9% of the people had these lung lesions in the beginning, 4.6% at the end of 1 year, and 3% at the end of 15 years. So similar findings were seen in the MERS study also. The common lung function abnormalities were impaired diffusion capacity, which was seen in almost 40% of the patients. And there are restrictive ventilatory defects. In case of COVID-19 pneumonia, we have data for a short period. So here in one of these good studies, we see that chest CT was done on the last day of discharge and at 2 weeks and at 4 weeks after discharge. The focal multiple ground glass opacities, consolidation, septal thickening, all were compared with the discharge CT. It was observed that the lung lesions of 65% of the patients were completely absorbed after 4 weeks. It indicated that a significant number of moderately severe COVID lung disease people, they recover completely and it is reversible. So it's important that you treat these moderate people adequately to prevent them from going into severe COVID. The potential role of antifibrotic drugs in preventing as well as treating pulmonary fibrosis is also studied. What are the treatment options? Currently, there is no fully proven options available for treatment of post-inflammatory pulmonary COVID pulmonary fibrosis. Prolonged low-dose corticosteroids may prevent remodeling of lung in survivors. However, the risk-benefit ratio has to be assessed as there are many fungal infections reported with prolonged use of corticosteroids. Antifibrotic drugs like pirfenidone and nintedanib are tried, but the use should be individualized because pirfenidone is known to cause hepatic abnormalities and ninte is known to have bleeding episodes in these patients. Rehabilitation in the acute stage and particularly in the recovery stage is beneficial. There are CT changes of acute lung complications of COVID-19 has been studied well, but there are many areas of uncertainty because clinical and functional significance of these CT findings is not well correlated. And we still don't know the relationship between pre-existing interstitial lung disease and post-COVID-19 fibrosis. There is no pathological correlation of CT findings. And we still are not clear about the long-term outcome of these CT findings. And we also are not clear about the predictors of improvement versus progressive fibrosis in these patients. So to summarize, two learning points for this is advanced age, severe disease, prolonged ICU stay, mechanical ventilation, smoking, all these are risk factors for severe respiratory failure post-COVID. A good dual source CT scan with pulmonary angiogram is suggested in all patients with dyspnea following SARS-CoV-2 infections. Pulmonary function tests are definitely helpful in picking up these patients. Organizing pneumonia, which is regarded as glucocorticoid sensitive, is to be picked up. Secondary bacterial fungal infections, cardiac dysfunctions like myocarditis have to be specifically looked for. Pulmonary embolism as a treatable post-COVID cause of respiratory failure should not be forgotten. And post-COVID pulmonary fibrosis is the most worrying complication with no proven therapeutic options. Thank you.
Thank you, sir. Now I would like to request Dr. Simal Jha to kindly introduce our next speaker for the day.
Do we keep the questions at the end?
Any questions?
Is Dr. Vinod slated for today or tomorrow?
For Dr. Vinod Singh is for today, sir.
Okay. So our next speaker is Dr. Vinod Kumar Singh, who is a consultant in critical care and is a director of ECMO program at prestigious Sir Gangaram Hospital in New Delhi. So I invite Dr. Vinod Singh to take the session forward.
Good afternoon to all of you. It's my great pleasure to be part of the World Conference of COVID and Critical Care. My sincere thanks to the members of the organizing committee for inviting me to talk on extracorporeal CO2 removal in COVID-19 ARDS. So I'm going to talk about the concepts, applications, and what are the evidences for extracorporeal CO2 removal in ARDS patient. And I will start my presentation with a case. A 57-year-old male with a history of hypertension presented to our hospital with severe ARDS secondary to COVID-19. The patient was intubated outside 7 days prior to transfer and he was referred to us for further management. The EVG revealed pH of 6.9, PaCO2 of 120 mm Hg and PO2 of 93 mm of Hg on 80% of FiO2. Because patient had acute hypercarbia and respiratory acidosis, so extracorporeal CO2 was initiated with a CRRT platform and a sweep gas of 3 liters per minute and blood flow of 500 ml per minute was started. A repeat ABG was done, which improved and a pH of 7.17 and PCO2 of 80 mm of Hg. On day 5, there was a significant improvement and the patient PCO2 was 55 mm of Hg with pH of 7.27. He was weaned off from the extracorporeal CO2 removal machine and his hospital course was prolonged because of the hypoxemic respiratory failure. He also required a dialysis for the renal failure. Patient was trachestomized and he was successfully weaned off from the ventilator. So here we see that the patient, the extracorporeal CO2 removal was successfully used for management of acute hypercarbia and acidosis. So there are, if you look at the extracorporeal CO2 removal at present, it is being used either to facilitate the lung protective ventilation strategy, or it can be used as a rescue strategy for a hypercapnic acidosis that is refractory to mechanical ventilation, as in our patient. So if you look at the pathophysiological rationale, why it is beneficial and why it is to be used, it can be divided in two parts. One, the patient who is receiving conventional ventilation, where the tidal volume of 6 ml per kg body weight and a restriction of the plateau pressure is 30 centimeter of water. Here, if the patient starts accumulating the carbon dioxide and leading to hypercapnia and acidosis, this can be used as a rescue treatment for removal of carbon dioxide. The second situation, it can also be used as an adjunct to the ultra-protective lung ventilation to minimize the ventilator-induced lung injury. Here, the tidal volume is 3 ml per kg body weight with extracorporeal CO2 removal can be used. If we look at the present era, one of the target of mechanical ventilation is to decrease the intensity of mechanical ventilation, like to decrease the tidal volume, to decrease the driving pressure, to use the less amount of PEEP and to use less amount of respiratory rate, so to decrease the intensity of mechanical ventilation. But one of the consequences while decreasing the intensity is hypercapnia, which can lead to pulmonary artery pressure, increase in pulmonary artery pressure, IV dilatation, shock, and eventually death. So to overcome this problem, if we are decreasing the minute ventilation to decrease the tidal volume, if we are decreasing the tidal volume to decrease the minute ventilation, this extracorporeal CO2 removal can be used as to manage the rise in the PaCO2. There are two basic principle how the extracorporeal CO2 removal acts. One is that the CO2 is mainly carried out by plasma. It is dissolved in the blood and there is a linear kinetics. So 1 liter of blood can carry about 500 ml of CO2, and other thing is the CO2 diffuses more readily in comparison to the oxygen. So it is possible to remove the CO2 with a higher sweep gas flow and a lower blood flow. If you compare with the oxygenation in extracorporeal membrane, we need a higher blood flow and lower sweep flow. In contrast to that, if you want to decarboxylate the blood, we need a high sweep gas flow and a lower blood flow. And this was a study which was published in 2015. There they found that in patient who has got a severe lung injury, ARDS, using extracorporeal CO2 removal can minimize the minute ventilation, and we can achieve a minute ventilation up to 50% reduction in the minute ventilation is possible by using the extracorporeal CO2 removal system. The technique is drainage of the blood. Here you can see the veno-venous extracorporeal system, where the blood is being drained from the femoral vein by a pump, and then again blood is going to the membrane oxygenated. There the blood is getting decarboxylated, and a decarboxylated blood is going back to the internal jugular vein, from where it is going to the systemic circulation. This is veno-venous extracorporeal CO2. Besides that, a arteriovenous extracorporeal CO2 can also be done where there is the pump is not required, but the MAP or the main arterial pressure is being used as a pump to propel the blood to the membrane, and here the decarboxylation is taking place. The problem is this: we need at least a MAP of 70 mm of Hg, and there are lots of complications related to arterial cannulation, like AV malformation and bleeding. So this is not this is not being used as a technique for CO2 removal. Here we can see that the femoral artery and the membrane lung and the femoral vein, the decarboxylation is taking place. There is no pump here. The pump action is being done by the MAP. This is VV extracorporeal CO2 removal. The double lumen cannula is being used. One is the drainage cannula, by which the blood is being drained by a pump going to the membrane lung, and a decarboxylated blood is going back to the systemic circulation by the same cannula. Like this is just like a dialysis catheter. So it is also called respiratory dialysis. Here the dialysis platform is being used in the extracorporeal this membrane lung is attached with the dialysis machine. This is a sled machine where the extracorporeal CO2 removal is being taking place. So if you look at the clinical applications, the indications and contraindications, the indications are basically to minimize the lung injury and to rescue the hypercarbia. Any patient who has got a driving cruiser more than 20, P-plat more than 30-35, PCO2 more than 60, pH of less than 7.25, respiratory rate more than 30, PaO2 ratio less than 150, and PEEP of 8 to 15. These are the patient where it can be used basically as a rescue treatment because the PCO2 is going high. The contraindications are those patients who requires ECMO are not obvious the candidate for extracorporeal CO2 removal. Patient who has got a severe heart failure, patient who has the contraindication for anticoagulation, and there is a poor survival for other disease or comorbidity, they are not the candidate. If we look at the trials and the evidences for the extracorporeal CO2 removal, the EXTRAVENT study trial, which is a feasibility trial, and the treatment arm and the control arm was the conventional protective ventilation, and the intervention arm less than 3 ml per kg body weight with extracorporeal CO2 removal. And they concluded that it is possible and feasible to use extracorporeal CO2 removal and to minimize the tidal volume. Here, there is no pump, and only this arteriovenous CO2 removal system was used. The supernova study, again, it was a feasibility trial where the strategy of ultrafiltration ventilation with the extracorporeal CO2 removal was used in a new onset moderate to severe ARDS patient. And the authors found that the ECO or the extracorporeal CO2 removal facilitate the ultraprotected lung ventilation. And they also concluded that a randomized clinical trial required to assess the overall benefit and harm of such type of treatment. This is a small study of 12 COVID patients who had a severe severe ARDS, where there was a hypercapnia and refractory hypercapnia and very low compliance. And they found that the low flow ecosystem was based on CRT platform, enabled the removal of CO2 and could be decrease the driving pressure, P-plat significantly. So they concluded this is in cases of COVID-19 with severe hypercapnia and very low compliance. This is one method which can be used to as a rescue treatment for removal of carbon dioxide and to minimize the respiratory acidosis. Again, the CRT platform, this system was used in COVID patient. This was the most recently published trial of extracorporeal CO2 removal, where the control arm was a conventional ventilation low tidal volume, and intervention arm was lower tidal volume with extracorporeal CO2 system, and they checked the 90 days mortality, and they could not find any significant benefit of mortality in using extracorporeal CO2 removal in patient with severe ARDS in comparison to conventional mechanical ventilation. So to conclude my talk, the technological advances have created an opportunity for an extended use of extracorporeal CO2 removal system. It should be considered as a therapeutic adjunct, as a rescue at present, and moderate to severe ARDS combined with further decrease in the tidal volume. The current evidence on their impact on the survival ARDS is just accumulating, and more data will be needed before this technique can be used and incorporated in routine use for the management of severe ARDS patients. Thanks for your patience listening, and I'm happy to answer any question related to this topic.
Are we using this technique routinely in India?
Yes, sir. In some places it is being used. In our center, we are using in patient who has got a severe ARDS and accumulating the PCO2. And also many ECMO centers, they are using this extracorporeal CO2 removal. But of course, you are not using the standard machine. You are using a dialysis machine as a platform for the extracorporeal removal of CO2. The standard machine like Hemolog or A-Lung is not available in India. Yeah.
Good afternoon, everyone. I, Dr. Kajal Gupta, welcoming you all to the first international session of the World Conference on COVID and Critical Care. Honored to have our extreme faculty and speakers who all are with us today. To chair this session, I welcome Dr. Kishore Mandal and Dr. Raymond Savio. Now, I would like to request Dr. Kishore Mandal, Senior Consultant in Critical Care at Eternal Hospital, Jaipur, kindly please introduce our first speaker, Dr. Charles Frunk, Director Emeritus Professor at Hadash Hebrew University Medical Center, Jasulia.
All right. Maybe
My co-chair isn't there. Fine. Dr. Raymond here, and I take over this session. Thanks a lot. Thanks to all the participants, delegates who've been here around. We've had a wonderful beginning to this conference, and there's so much of COVIDology that we've been listening to. Thanks to the organizers, particularly appreciate Dr. Narendra Ranta and his team. So over to the next session, we're going to be listening to a whole lot of senior experience from around the world. And for today, we have with us a couple of people who are going to share their experiences from Nepal, Kenya, Israel. Our first topic for the session is about Israel experience, and to deliver that, we have Dr. Charles Sprung with us. He is the director and emeritus professor at, I'm sorry if I'm pronouncing that wrong, Madrasa Hebrew University Medical Center, Jerusalem. Okay. Without taking too much of your precious time, let me pass on to Dr. James. Please, sir.
My topic for today is dealing with the COVID pandemic, the Israel experience. I have no conflicts of interest, and I will try to explain to you exactly how we dealt with the corona pandemic in Israel. As you all know, the COVID-19 was classified as a pandemic by the WHO on March 11th, 2020. Several countries, including China, Spain, and Italy, were overwhelmed and lacked adequate numbers of ventilators, ICU beds, or PPE. Various medical societies produced triage guidelines recommending using social work, and some countries even used age as a triage criteria for intensive care unit admissions. Here is one reference to the Italian doctors. Now, during this time, I contacted some of my colleagues in China, in Italy, and in Spain to assess the situation. And in fact, the situation was terrible. I heard descriptions of patients dying in emergency rooms because of lack of staff, ventilators, and it was much, much worse than any epidemic we had ever dealt with. Because of that, I contacted colleagues who I had worked with previously on ICU triage during normal and during epidemic situations to update protocols which we had. During the H1N1 epidemic, the European Society of Intensive Care Medicine had developed recommendations for influenza epidemic and mass disasters. And in fact, there had been previous recommendations by the Society of Critical Care Medicine related to triage. And we did an ELDICA study and updated the triage to intensive care unit patients also. We came up with adult triage recommendations, also with an algorithm, which I will describe for you, to help improve the survival during the COVID-19 pandemic, which seems much, much worse. Now, those were international guidelines developed by an international panel of experts. I received a call at the end of March in 2020 by the director of the Hadassah Medical Center to set up and chair a new Hadassah COVID-19 ethics committee. As this was a national issue, I didn't think it was appropriate to do at one hospital, and I involved the chairman of the Israel Society of Critical Care Medicine to appoint a representative. I had a representative from the Ministry of Health to help us develop something for Hadassah, but which would be able to be used for the entire country. After several Zoom meetings and the evaluation of several potential tools, after 1 week, the committee sent their recommendations, which included general principles and a protocol, which was very similar to the one just recently shown for critical care medicine, to Hadassah, to the Israel Society of Critical Care Medicine, and to the Ministry of Health. Now, shortly thereafter, a few days later, I was contacted by Professor Avram Steinberg, who was appointed by the Director General of the Israel Ministry of Health for having the National Bioethics Council, of which Professor Steinberg was the chairman, to develop national guidelines for triaging severely ill patients if the healthcare system was overwhelmed. Now, this commission consisted of the Israel National Bioethics Council, the Ethics Bureau of the Israel Medical Association, and the Israeli Ministry of Health. The committee was subdivided into 4 subcommittees: a medical, legal, philosophical, and halachic or religious subcommittee. And before meeting, the Hadassah, Israel Society of Critical Care Medicine, and Ministry of Health committees sent their previous recommendations that we developed for Hadassah to the medical subcommittee of this commission. Now here you see the co-chair people of the commission, this medical subcommittee, the philosophical, ethical, and social subcommittee, legal subcommittee, and the religious subcommittee. All these individuals were experts in their fields, known nationally and many of them internationally. And for the religions, we covered the 3 major religions. Now, in general, the commission guidelines provide general principles and pragmatic medical criteria and a practical triage protocol. The guiding principles included supreme value of life, equality of all individuals, transparency, consistency, equity and access, fair distribution, greatest good for the greatest number, compassion to all patients, and promoting public trust. Now, we needed to address issues of several constituencies. First, the general public, explaining to them for the necessity and application of excruciating decisions in extraordinary circumstances while trying to maintain mutual trust, and for the healthcare professionals who are working under extreme duress, provision of succinct, practical algorithms. Now, the triage guidelines take into effect only after Ministry of Health declares a transition to an emergency state after many, many efforts were used to expand or obtain additional resources which failed. Now, I must say we're at the end of the 4th wave in Israel, and to date, we have not had to use the guidelines recommended by the Commission. Prioritization is solely based on an individual basis without any discrimination based on a group or such as age or disability. Prioritization is only on a medical basis with short-term survival being looked at, not according to the remaining years of life. Several tools were evaluated, and we decided on an algorithm similar to the one that was used in the International Critical Care Medicine paper that I showed. The algorithm was simple, easy to understand, used multi-dimensional assessment measures predicting short-term survival and leading to the quickest decisions. We used the same exclusion and inclusion criteria and the 4 prioritization variables as we had used in the Critical Care Medicine paper. As far as age, which was controversial, chronological age is not a legitimate standalone criteria for triaging scarce resources, and this includes intensive care unit beds and ventilators, and should only be considered as part of the combination of risk factors. Furthermore, the goal is to maximize the number of lives saved rather than life years saved. We decided on lives saved rather than the critical care medicine group's use of life years saved. Healthcare professionals should not be given upfront priority, even if infected while treating COVID-19 patients, and only if absolutely necessary to overcome staff shortages, and then only where there's a tie situation. The state will ensure a fair distribution nationwide of ICU beds, ventilators, and skilled professionals according to population density and the expected and actual demands. And institutional triage committees are only to be used for consultation and not for actual triaging the patients themselves. Now, after viewing by the general public, there were some complaints that came from various organizations, specifically people with disabilities, as one of the inclusion criteria, which I will discuss later in the development of the international recommendations and algorithm that was published in Critical Care Medicine. We used performance metrics, which the disability groups felt discriminated against them because they had disabilities and they had a lower chance of being admitted to the intensive care unit. The committee viewed the performance tools necessary for equitable prioritization and which are applicable to all groups, including the elderly and patients with various illnesses. Subsequent amendments were made to the original proposal. They did not change the actual paper's essence or the various parameters that we used for making the triage prioritization, but we made it more clear that prioritization is only based on medical considerations and not others. As in Israel, things are very, very different than most other countries. We are not allowed to withdraw ventilators. It's against the law. The question came up, if we did not have enough ventilators, should we as a commission talk about new legislation for allowing the withdrawal of ventilatory support in patients who were dying of COVID-19 and who perhaps the ventilator would not help them anymore when we could be using the ventilator for someone else. The commission was split on this issue, but decided that since a decision was not presently required, it could be postponed until necessary. And under those circumstances, if a change had to be made, we could make it very quickly. Now, the process that we went through in Israel, I've gone through various steps that we went through. You can read about this in a Israel position paper that we published in CHEST last year. And we talk about the governmental, professional, and public involvement. The support of the national government was extremely important, but we also had input from medical institutions, societies, and governmental agencies. And the public discourse is important, time permitting, and we were able to change some of the recommendations based on that. It's important to have recognized experts in multiple disciplines as we had. You can see them here. And in terms of developing the guidelines, it's important to identify not only simple issues, but as these are controversial issues, we should include those by the experts so we can develop something that will be acceptable to all of society. And I talked about the division of the various subcommittees was extremely helpful, and combining the subcommittees to develop consensus was important. And further refinement was developed with public discourse, which was very helpful. As far as the document itself, again, multiple constituencies, important to have a language that people understand. And again, the algorithm must be concise, simple, a clear medical flow sheet and tables so that physicians can use it in real time and do it very, very quickly. We customized our document for the local realities, cultures, and regulations and laws, and your countries may be very different, and you should customize it for your country. The actual specific recommendations of the Commission were published. Here's the publication, and this is the English link if anyone would like to see it. So I've tried to go through with you how we dealt with the COVID pandemic very, very early on, developing a national guideline for use for all hospitals and institutions in the country, and we believe this is the only country that has a national policy for triaging ventilators and intensive care unit beds if necessary during the pandemic. Thank you very much.
Yeah. Thank you so much, Dr. Sprung. That was a very careful deliberation, and it was really enterprising to listen to your experience. And of course, so many of them were quite an eye-opener, but there was something that really caught my attention. Before we discuss that, let's see if there are any Q&As that have come up from the participants, from the delegates. Probably not. So it was very nice to notice that chronological age was not given importance, but were you really able to stick to that policy? Dr. Sprung, if you're there to address this query.
Yes, So I've tried to start my video, but I guess you have to turn it
That's
off.
absolutely okay. That's fine.
Oh, here I am. So as I mentioned, we are actually after the fourth wave here in Israel, and we have not had to use the various algorithms developed by the International Committee and those accepted by the Israeli Commission. So I don't know. I think different people in Israel and other countries have told me that they have used our algorithm. And most people do not, or at least what they tell me, have not used age as a sole criterion to make triage decisions. I think as part of the algorithm, there are other parameters in terms of underlying disease, and obviously older people have more underlying diseases, so they might have other reasons not to be accepted. But based on our ELDICA study, there's no doubt that older people are discriminated against on a daily basis around the world, and are typically not admitted to ICUs. But we say it's because of their underlying disease, but many times it's really based on their age.
Yeah, absolutely. I take that. I mean, a little out of COVID. So in these patients, would you actually monitor frailty scores, or what exactly would you? I understand. Otherwise, disease scores, yes. But apart from the chronological age, was there something else that you were actually actively looking into? Was it frailty?
So I'll go through this more in depth in my talk, which is going to be at 1800. But there were several parameters. One was a performance score. We decided to use the ECOG, which was a performance score developed in oncology rather than the frailty score, because there were only 5 parameters as opposed to 9, and it was much, much quicker to use. We did state in the critical care medicine paper that those countries that are used to using one score versus another, like the frailty score, should certainly be using that. In terms of comorbidities, we used an ASA score. And then we also were looking at what the physician thought the prognosis was in terms of survivals, more than 80%, less than 20%, and another parameter. So it was 4 different parts, and I'll talk more about that in my talk at 1800. So stay tuned.
Oh, yes, of course. Any questions? Do we have any queries? Similarly, there was another thing that did catch my attention, that was the lack of prioritization for healthcare workers. That seems to be a little hard.
Well, it's hard if you're a healthcare worker, but if you're the public, doctors making recommendations to take care of their own would not sit well. So we were concerned about getting acceptance for our recommendations from the public and getting trust, which I think is the most important thing during a time when we cannot provide the typical modalities which we would under normal circumstances. So because of that, we did not give a priority for healthcare workers. The feeling at that time was that most healthcare workers who got COVID and had to be in the intensive care unit probably were not going to come back to help take care of patients. Therefore, we would not prioritize them. But if there was a tie, they would get it in. We in our committee at Hadassah have thought about looking through this again, because after going through several waves of COVID, we have seen several healthcare workers, doctors, and nurses who have had COVID. One of the authors who was helpful in the critical care medicine paper was even in an intensive care unit, went back to taking care of patients. So our hypothesis that people would not get back to be taking care of patients was not true. And many, many countries have had problems with inadequate staffing, doctors, mostly nurses, who have left the profession. So we have to think twice about this now. And if in fact we do not have enough people to take care of our patients, we might have to rethink about prioritizing healthcare workers.
Absolutely. So thank you so much, Dr. Sprung. It was wonderful interacting with you. If there are no more questions, maybe in the good interest of time, we should move on to the next speaker. And thank you so much for joining with us. Yeah. So as our next speaker, we have with us Professor Reena Shah, who is a consultant physician and specialist in infectious diseases from Aga Khan University Hospital, Kenya. And I'm really looking forward to listening to the lecture. Over to Dr. Reena Shah.
To speak today on the World Conference on COVID and Critical Care 2021. My name is Reena Shah, and I'm an infectious disease specialist. I'm based in Kenya. For those who don't know, we're a little country in East Africa. You can see it with the yellow arrow. We're based along the Indian Ocean. So since March 2020, when we had the first confirmed case in Kenya, we've had a total of about 250,000 confirmed cases with about 5,000 deaths, giving a case fatality rate of 2.1. And majority of these cases were local transmission, and only about 3% were imported cases. And to date, as you can see from the slide, we've had 4 waves of the pandemic. And from March and November last year, early this year, we're literally just coming off our 4th wave. Also, you can see majority of our patients have been asymptomatic, the yellow bars. So we've had a case fatality rate which went along with the waves of 2.1%, and deaths about 5,100 patients. Majority of our cases were asymptomatic, 91%. Only 9% of our patients presented with symptoms, as is mirrored in the rest of the world. The commonest symptoms were cough, fever, and difficulty in breathing. If you look at the age group, majority of our patients, as shown as the rest of the developing countries, were middle-aged. Majority of our patients were between the age of 20 to 60, and we had more males than females in the distribution, and that's also what's been shown in other countries. And the deaths have been higher in males. The blue bar is the males and the orange is the female. If you look at it, majority of our deaths have been male. And of course, as shown elsewhere in the world, the elder you are, the more likely you're to die of COVID-19. So majority of our deaths, 36%, have been above 60 years of age in the male population. And we've also had a lot of healthcare workers who've been infected, and of course, as expected, the infectivity in the healthcare workers goes along with the waves. So we've had about 7,600 patients, healthcare workers infected with COVID, of which we've had 51 deaths, unfortunately. So as seen in other parts of the world, the urban areas are more affected. If you look at the dark yellow and the big red dots, majority of the infections and deaths have been in the urban areas, and Nairobi, which is the capital city, is where the middle cluster is. The second largest is Mombasa, which is along the Indian Ocean coast, where you expect the ports of entry of people bringing the virus in, and then the distribution of the virus. So urban areas have been worse hit as compared to the northeastern and the north areas, which are sparsely populated. So as the pandemic has gone, if you look at the yellow, we've had more and more home-based care and less admitted to hospital, which works as we've learned more about the virus. Initially, a lot of patients were admitted to hospital, but as the pandemic has evolved, and as in other countries, doctors have been more comfortable with patients being managed at home, the home-based care has increased and continues to increase. Our vaccination rates are very low. We're very envious of India, which has got one of the highest vaccination rates to date. To date, we've only vaccinated about 3 million of our population, of which 53% are male and 47 are female, and fully vaccinated are just about 1 million. So we're really lagging behind in our vaccination rates. This is just showing what we were doing in our hospital, and our admissions mirrored the waves we were getting in the pandemic in the country. So As the country had higher rates of COVID-19, so did our hospital. And this is our real life data from our hospital. So I work at the Aga Khan University Hospital as a tertiary teaching hospital. And since March 2020, all admissions, regardless of what you came for, whether it was maternity or you came in with a road traffic accident, you had to have a pre-admission COVID test at no added cost to the patient. And what we found is we had 1% of our patients had incidental COVID, meaning that they had no symptoms or signs of COVID. They came in for routine care, and we found 1%, so 1 in 100 had incidental COVID, and ended up being moved to the COVID ward. So this pre-admission screening assured patients that they were not lying in a bed next to somebody who was COVID positive. It helped us as caregivers and healthcare workers that our patients that we were looking after did not have COVID. And so it reassured us that whatever we were doing was correct. And it reduced anxiety amongst patients and staff. If a patient came in an emergency, so for example, an emergency C-section, or RTA, the initial care, we assumed that the patient was COVID-19 and wore the full PPE. But in those that we had a negative test, where we had time, they were moved out of the isolation ward and given normal care. So COVID-19 has given us a reminder to reason. You know, we've got to really think of our perspective when we manage these patients. And looking at this, you know, there are so many doctors, healthcare workers that were giving patients so many medications. And we realized in COVID-19, probably the only thing symptomatically that would work was paracetamol. So, you know, we needed to simplify these 10, 15 drug regimens into just paracetamol. And the other recommendation, we follow the NIH guidelines. You know, we really did not use the antibiotics or HCQ. We have not used ivermectin, colchicine. We did not use steroids when the patient did not require oxygen. And empiric antibiotics was a total no-no. And really, there is not much evidence on using the vitamins zinc and acetylcysteine. And very early on in the pandemic in our hospital, we stopped using all these medications. But what I believe and what we believe COVID-19 has taught us is that we've got to do studies. We've got to see studies for what works worldwide, what works in our population. So we've been part of many clinical trials, tocilizumab being one of them, where we showed that in a patient who was deteriorating with increased inflammatory markers, worsening oxygen requirements, probably some intervention was important rather than giving it blanketly to every single patient. So the way we worked with our hospital, we formed a task force with senior leadership, including the CEO, dean, the nursing officer, all departments were included, including maternity, obs and gynae, surgery, nursing, pharmacy, MMD, laboratory, IT, and the research department. And we had daily meetings to discuss how we were going to manage the wave, what we're going to do, how it would work. And with the involvement of senior leadership, you could see that it penetrated down to the lower echelons of the hospital in managing the COVID and taking it seriously. So to summarize, you know, it's uncharted waters. There are no experts. We know more about the virus now than we did a year ago, but we also realize it has to be a multidisciplinary approach. We need to network and learn from each other, not just within the country, across borders, as we're doing today. Hand washing, social distancing, very important. You need to have a very high index of suspicion for diagnosis. For example, a patient coming with fainting, we've had patients, you know, rare symptoms where patients have presented with COVID-19. Should all hospitals adopt routine testing in a pandemic like we did? I think it did help our care and made patients and healthcare workers very comfortable in what they were doing. I believe treatment must follow evidence. Let's not just throw anything and everything at our patients. And prevention is still better than cure. And vaccinate. Vaccine is very, very important. So if we look at Africa and where we are, we're amongst the lowest vaccinated rates in the world. And hopefully as we scale up with COVAX and other vaccine donations, we hope we could go to the dark green bar as Europe and North America. And I think the one thing we've learned and we're seeing in the world that we've got to have equitable distribution of vaccinations. Africa and the developing world is lagging behind, and we really need to reach up. We're one world. We're as good as our weakest link. And if Africa is not vaccinated and continues to harbor the virus and have very sick patients, it's going to affect the countries that are vaccinated with the new variants coming. So we all have to work together. And I think this is one COVID has taught us, that we really are one world. And pertaining to Africa, we've had borders closed, we're restricted travel, but we are opening up. And what Africa has realized is that we have to have healthcare in country, county, town, and village. You can't just have the capital cities and the towns that have good healthcare and the villages don't. With closing up of borders and closing counties, there are some areas that did not have good healthcare, and that's been a really big lesson learned. I believe solutions are different for Africa, and every country, every region has their own solutions. There's a lot of cost attached to the testing and treatment of COVID-19. But as we do that, we mustn't forget our other diseases such as HIV, malaria, Ebola, which continue to have more deaths and have killed more people even during the pandemic. And we should continue doing more studies and trials within our own countries. And thank you very much for your attention.
Thank you so much, Dr. Reena Shah. That was a wonderful deliberation, and of course, it was very nice to listen to your experience, especially your last take on the equitable distribution. The world is just as good as its weakest country, so we can't agree more. We probably have a couple of minutes to take some questions from participants, and maybe until there are any questions, I would like to hear from you about the extent of governmental involvement in coming up with policies and rationalizing resources and things like that. So what was there some kind of a society or some kind of an organization that was set up in your country, and what was the contribution by healthcare workers or physicians to such an organization? If I can hear from you. Dr. Reena?
He's not there, sir.
Okay, I'm just afraid if Dr. Reena hasn't been able to join us, we may be able to take questions from participants. I mean, if there's something that I can really help you out with, else we may just have to move on to our next speaker. Can we move on to our next speaker then? Yeah, I think we may have to catch up with time. Yeah.
Now I would like to request Dr. Kishore Mangal, Senior Consultant in Critical Care at General Hospital, Jaipur. Kindly please introduce our third speaker, Dr. Chariraj Premkul, MD and Department of Medicine, Siriraj Hospital, Bangkok, Thailand.
Good afternoon, Dr. Chairath. We welcome you to this World Critical Care Conference, and we would like to hear from you for your Thailand experience.
My topic is Dear Mr. Chairman, my topic today is the challenge, phase, and strategy practice during pandemics in Thailand experience. My name is Chariraj Premkul from Department of Medicine, Siriraj Hospital, Bangkok, Thailand. The story of COVID infection in Thailand started right after the outbreak in China, where the first case from China was reported in Thailand in January 2020. And 1 month thereafter, their first outbreak in our country is in many clusters. And this situation is well controlled by the government's policy of declaration of state emergency and and the restriction of activity of the people, curfew and lockdown. So this first situation was well controlled. The second outbreak again started in a small province, 50 kilometers from Bangkok. Infection started in the factories with a lot of immigrant workers and Thai workers also. They live together in very crowded area. This outbreak was controlled, but more difficult than the first one, but they are well controlled. Not many patients, not exceed 1,000 patients were reported. And throughout the year 2020, the situation was well controlled as noted. And the third outbreak, this is the countrywide outbreak, start during the Thai holiday season in April, where a lot of people throughout the country celebrate again. Then there was no restriction on that at that time. So when the infection start, then there are no policy to control. So there are countrywide outbreak. As you can see, the first patient from January 2020, and yesterday the case was 1,700,000 cases already. As for the vaccination, the government cares a lot of vaccination, and they try to procure to import the vaccine, and vaccination was started in February, but small amount of vaccination was started from the beginning due to short supply. And after the condition get worse, they try to get more vaccine. And as you can see, when heavy vaccination start at the beginning of August, the case come down. And now the infection rate here, the count of yesterday was the new case, 11,000 and total of 700,000 cases. And at the moment, 600 patients were ventilated, and the mortality was 1.23%. So I'm not quite sure that we are out of the third episode or not. But let's see, because in the area outside Bangkok where vaccination are not very much, there are still a lot of infection and cluster in the southern part of Thailand at the moment. We do use international guideline according to the mild, moderate, and severe case of COVID. This is one example of the guideline for COVID pneumonia, where oxygen, high flow cannula, position, and mechanical ventilator, together with the use of steroid or anti-inflammatory agent and mechanical ventilation, including ECMO, included in the guideline. In our hospital, this is the picture of our hospital named Sirat Hospital, which is the first medical school in our country. You can see we have to take care of the patient from the beginning. The patient come to the hospital with the URI symptoms suspected to have COVID. So we set up ARI clinic, and we have to set up ICU. We open more than 20 heavy ICU case we call AII ICU. And we modify the old ICU to be modified AIR ICU also. We set up the field ICU as well in the capacity of more than 40 beds during the peak time. And now we have maybe 14, 15 cases of severe pneumonia. As for the case of impending severe case where the people need to have a high flow oxygen cannula, we set up the non-ICU COVID ward. We don't have many facility with negative pressure. So we use our old building with the open air system, and we make partition between the nurses and the patient area, and we open the patient area to be free airflow and make the airflow thoroughly, and by the use of protective device, we can open this kind of ICU ward to be more than 180 beds during the peak. Right now we have 60 beds at the moment. So I can say that the situation is well controlled, but I cannot be sure that new case will come up or not. So as for the challenge of our city of Thailand, I can say that we take care of the patient with serious pneumonia or serious organ failure, and the amount of patient depend on the amount of the patient who got infected. So the challenge in our country is the failure to control disease dissemination, which is depend on the control policy of the government and the ability to control the cluster outbreak. And we need to control the patient non-adherence, or we need to control the patient adherence to the sanitation, distancing policy also. And as for Thailand, we have not only for Thai people, we have workers, immigrants from other countries. So we have to take care of them, and we have to integrate the foreign and working and sanitation and public health together. When this business cannot go along, there might be obstructed flow, which we experienced during the at the beginning. And the access to diagnostic tests, we have the problem of the use of diagnostic device or test. In the beginning, we use only PCR, but it takes a lot of time and to have the test done and the report, and the medication bit is delayed. And later on, we accept antigen test kit, which is more convenient. And the last thing is the same as many countries, which are the space and staff and the supply of the ICU, which is very hard to cope when you have a large amount of the patient. So the failure of the disease control end up with the large number of patients. The failure of tests result in delayed diagnosis, and the poor supply of the space and staff and ward may be coming with the poor outcome. So we cope with this situation with improved decision making from the government, and we put a lot of things in the media, and we try to improve management and the strategy and use of IT and use of the accumulate the knowledge. As for the diagnostic test, we update our knowledge, and we try to convince the policy maker that although the antigen test kits are not very absolute effective, but we can use it in rapidity. And as for the ward, we prepare and the new area, and we set up the field ICU. We open the silent ICU like the recovery room and the OR in some hospital to be the COVID ICU. We put the old building to be the ICU, and we import doctors and nurses from the non heavily infected area to in Bangkok during the huge episode. Doctors and nurses from other provinces of Thailand come to Bangkok to help. And I believe in the next time we have to improve our self ability to cope with this improve the ability of our country to produce vaccine or to better face the next crisis. We are studying the use of Thai herb like Andrographis paniculata and Bosenbergia rotunda, which is proof in the lab that works well to stop virus, and now we are running RCT to prove it. So our recommendation from our experience is that we suggest that the prevention of infection is necessary, so that we can minimize the amount of the patient, and we have to prepare adequate resource and effective management and collaboration between unit and unit. And the key success area is the early diagnosis and early antiviral therapy. And later on, we don't have enough space, so we put the patient on home isolation and community isolation and have this volunteer to work for us. And from our experience, I believe that the use of steroid too much and antibiotics too much may be problematic, and we need to optimally use it. Awake prone positioning and Thai herb, and we have to better prepare for the next disaster. Thank you very much. My topic.
Thank you, sir. Now, I would like to request Dr. Kishore, sir, again, to please introduce our fourth speaker.
Thank you, Dr. Sharath, for your really interesting take on the experience from the Thailand on the COVID-19. And I think it was really an eye-opener that how different things are there in different countries. And I think there are no questions from the participants. So I have a couple of observations and questions from you. Dr. Sharath?
Yes. Yes, second, please.
Sir, so we had observed that the countries in Southeast Asia had virtually very low cases during the first year of COVID-19. And then suddenly this year, not only in Thailand, but also in Malaysia, Vietnam, and other countries, they had a real surge of patients. So what was the difference between the 2020 and 2021? Where the things went wrong?
Yeah. In my experience, I believe that the difference was due to the government policy first, because when the first hit come, people are all frightened, and the government were frightened also. So they put very strong policy. They closed the country. They put a lot of restriction policy, and people get along really well because they feared. And in the second episode, it's the same, but they are more relaxed. And when the third episode, from the first and the second wave, the economic status of the country was affected by the closing of the country, because we depend on tourism. When we close the country and we close things, people have very poor income. So on the third episode, during the New Year, Thai New Year, the government was reluctant to close the country or to do restrictions. So when they are relaxed and people are more relaxed, and more people get infected, and then things go far. We cannot control things. That's the first thing. And the second thing, I believe that the first episode was due to Wuhan strain. Yeah. The infectivity was not very high, and now we see the Delta strain, which yes, the infectivity is very high, and a lot of patients get to the serious illness. So I believe the two main things are are the important factors.
Yeah, absolutely agree. The Delta virus has been really, the strain has been very bad for most of the countries which did not have any experience before.
Yeah.
And I'm one more observation from his presentation was use of Thai herbs. So are you using it for only RCT purpose, or in general it is being used by the public and by the practitioners?
Yeah. First of all, when we start to have very huge amount of patients at the favipiravir and remdesivir were not sufficient, or they are inadequate supply of the medications at first. So our government and people try to find things to help, and we found that steroid help, but later on it posed a lot of complications. So people in various segments try to use Thai herb, and they try herb. The two things that I mentioned in my slide was used in the virology lab in the extract from those two herbs stop viral growth.
Okay.
And from the non-randomized trial, some non-randomized trial, they decrease the disease severity and decrease the seriousness of infection. I am running the RCT right now in my country, but the result hasn't come out.
Yeah, we'll be waiting for that RCT to be published and see the results.
Yeah.
And what was the experience apart from COVID? What was the experience of your non-COVID patients? Did you see any surge in other infections, or it was like in India, what we saw was that the tropical diseases were very less during the COVID times? So how was your experience in Thailand?
Yeah, the thing that we found might be the same as yours. Less people who got influenza and got other respiratory-borne disease, because we wear masks and we are very distancing. We wash hands very quite often. So other infectious disease decreased. And what I experienced is that metabolic disease did not decrease. And we have a lot of problems because we have to change one ICU to COVID ICU. This affects non-COVID patients. So some of the emergency patients cannot be admitted, and we have to refer them. So this is the effect on non-COVID patient also. But infection from the respiratory-borne infection all decrease.
Yeah. Yeah, so similar experience here in India also, that we the influenza cases went down dramatically, and now again it is showing increase this time around, because COVID situation is little better in our country right now.
Yeah. Yeah.
So thank you so much, Dr. Sharad. Dr. Raymond, do you want to add or ask something?
No, I'm fine, Dr. Kishore. I think we can just move on.
Yeah, okay.
Thank you so much. Thank you, Dr. Sharad.
Thank you very much. Thank you very much.
So we go on to our next speaker, Dr. Gentle Shrestha. He is assistant professor in Department of Anesthesiology at Tribhuvan University Teaching Hospital, Nepal. And he'll be discussing on experience in Nepal ICU in managing COVID patients. Please, Dr. Gentle.
Good afternoon, everyone. First of all, I'd like to thank the organizers of World Conference on COVID and Critical Care for giving me this opportunity to share the Nepalese experience about how we manage the COVID cases and how we dealt with the COVID waves in Nepal. I bring the greetings from the Nepalese Society of Critical Care Medicine and the Society of Anesthesiologists of Nepal. I have no conflict of interest to declare. Briefly about the country, Nepal itself. It is a landlocked nation in South Asia, with China in north and India in the south, east, and west. The land area is around 147,000 square kilometers. The population as of 2018 is around 28 millions, and the per capita GDP is around US dollar of 4,200. So if we see the case loads and the various waves we faced, and the first wave was around the mid of October 2020, and during the peak of those days, during the first wave, we saw almost around 4,000 new cases per day, and we faced the second wave around the mid of the May 2021, where we saw almost 9,000 cases, new cases per day, and at present we are seeing around 1,000 cases per day. Until date, we have around 800,000 infected patients, and around 11,000 patients have expired of COVID in Nepal so far. So we faced various challenges during the first and second waves. So during the first wave, we faced multitude of problems and challenges like the limited ICU beds, the limited infrastructures, limited supply of good quality PPEs, and the challenge with training and education of healthcare workers. So during the April 2020, we did a nationwide survey to see how well our hospitals in Nepal were prepared to deal with this pandemic. And we did an online survey, and we obtained almost 130 responses from all the 7 provinces of the nation. And we found that overall the preparedness of the nation was suboptimal. We found that only 40% patients in the hospitals had the policy to receive the suspected or proven cases at a time. And we found that only 7% of hospitals had airborne isolation rooms, and 90% of the hospitals, they expressed that they had inadequate supply of good quality PPEs, and the critical care services for COVID patients was possible in only 30% of hospitals, and only 5% of hospitals at that time was capable of doing the RT-PCR tests. Later on, we did a telephone survey that was conducted by the Nepali Society of Critical Care Medicine in the Kathmandu Valley, that is the capital city of the country. And we found that in the capital, we had around 480 ICU beds with around 260 ventilators. So as the cases started to increase, we had to make the makeshift ICUs, and one of the options was obviously to convert the post-anesthesia care units into COVID ICUs. This is a picture from our hospital where we converted one of the post-anesthesia care units into ICU. And those units, they didn't have the negative pressure system. So what we did was we installed the industrial exhaust fans so as to minimize the viral load. This is the way how we tried to mitigate the limited number of ICU beds during the peak of the pandemic. And the next challenge was to train the healthcare workers. And there was a big need for the training of the healthcare workers during the phase of the pandemic. And again, it was challenging to train the healthcare workers at that time because of the travel restrictions, and at the same time because of the COVID precautions, we had to exercise. So we tried with a pilot project with the e-learning programs with which we trained almost 60 healthcare workers from 5 different hospitals from different provinces. It was supported by GIZ. It was simulation based, and we found it to be effective and well taken. So during the second wave, we had a unique problem of oxygen crisis, and also we had the problems with various medications regarding their availability and their rational use. And again, we faced a problem with training and education of the healthcare workers. So during the second wave, the oxygen crisis was because of the various reasons, like there was a rapid surge of cases. We saw almost 9,000 new cases per day, and our limited resources was rapidly overwhelmed by the increasing number of sick patients requiring oxygen supplementation. Obviously, our preparedness was very poor, and despite the anticipation of this second wave, the preparedness of the whole nation was suboptimal. And at the same time, we saw a lot of people, they were hoarding the oxygen cylinders and PPEs, and thus creating the artificial shortage of oxygen over there again. And again, in various hospitals, major centers, we had the oxygen plants, but at that time we found that many of those oxygen plants were either non-functioning or they're functioning below the maximum capacity because of the lack of the maintenance. They were not maintained regularly, and that's why then the functioning was not optimal at the time. Also, we found that there was a leakage in the pipelines and from the flow meters and various places, and also the oxygen was not being used in a rational way, and oxygen was being wasted in many places. And also the local regulatory bodies was not that efficient to regulate proper oxygen supply. All these things together resulted in a significant oxygen crisis. So one of the things we tried to do was we tried to conserve and we tried to rationalize the use of oxygen. And in our hospital, we prepared a checklist for the use of oxygens. We set the oxygen targets. We made the strategies how we can optimize the use of oxygens, minimize the wastage. We did oxygen rounds, so as to ensure that this checklist was being followed in all the wards, not only in the ICU and also in other places where the oxygen was being delivered to the patients. Also, we tried to meet the need of oxygen by using various oxygen concentrators. We try to use the liquid oxygen to mitigate these problems, and also we try to fix the non-functional oxygen plants that was previously existing. At the same time, we faced various problems, like the public, they used to procure various medications from the pharmacies over the counter without the prescription of the doctors, and we found that many of the medications that were being overused or misused at home. Like many people with COVID and staying at home, they were taking the antibiotics, they were taking vitamins and all those medications that didn't have any evidence of benefit. Not only that, even in the hospitals, the use of oxygen was use of medications was not as per the evidence, and also there was problem regarding the supply as well as the use of various medications like dexamethasone and tocilizumab. We found that the dexamethasone and all the steroids were not being used as per the standard recommendation and as per the evidence. And at the same time, the drug like tocilizumab, there was significant shortage of this drug, and also the various people, they were hiking the price of these drugs during the time of crisis. And also we saw many cases of mucormycosis amidst the second wave that was really challenging to manage in places like Nepal with limited resources. And during the second wave, to train the healthcare workers, we again used the online platforms, online methods for the training, and it was supported by the World Health Organization this time. And with that, we were able to train almost 11,000 healthcare workers across the country during the peak of this second wave, and that to some extent helped us to increase the number of trained healthcare workers during the second wave. So we learned a lot of lessons during the COVID pandemic, and we definitely felt that we need a proper preparedness for the pandemic and for the future pandemics. Our preparedness to be better, so that we don't land up with those similar problems again in the future. Also, we need to prioritize and optimize the use of our limited resources. We should stick to and we should practice the rational use of medications. And also we learned that often less is more in patients with COVID, like in other critically ill patients. Thank you.
Any questions?
Yeah, Dr. Kishore, you have any questions to our speaker? No.
Thank you so much, Dr. Shrestha, for your nice presentation and your sharing your experience of Nepal ICU. I think we in India can all relate to all these experiences because we had similar experiences with the oxygen crisis, mucormycosis, and the other issues. Dr. Shrestha, is he here?
No.
He's not there, sir.
Yeah, Dr. Kishore, I think he had to log out, so he's not available with us. That brings us to the end of today's session in Hall D. Yes. Yeah. It was indeed nice listening to, like you pointed out, in fact, Southeast Asia, we had certain unique situations, certain unique crises, like what we heard from the Kenyan and the Thailand experience about drug misuse and, over the counter. These are certain things which probably the West and the higher income countries don't probably see. So is there something that you would like to share, Dr. Kishore? If not, maybe we should just wind up in good interest of time.
I think if we talk about this, the difference between the Indian and the other things, other countries' experience, I think just like Dr. Shrishth pointed out, that use of over-the-counter medicines and people getting medicines from the pharma counters directly, I think that was a major problem and probably led to compromised situation with the patients going to hospital in a very late stage and in complicated situations and having very poor outcome, not only from mortality point of view, but even if we saved them, they had a very bad post-COVID lung fibrosis and morbidity. So I think that was a big problem, and I think it was all over India that this problem had been there. There was the pharma counters were selling it like a package. Okay, you just go to the counters and the packet would be available and you can easily take it. Anyone can take it. Who's not seeing the age, the comorbidities and other things. It was just very funny, but it was a big problem. I think the government should look into all these things, and this should not have happened.
Yeah. So we had a wonderful batch of speakers, and it was really enterprising listening to their experiences. With that, maybe we should conclude the sessions right now in Hall D. Thank you so much. Thank you, everyone, for having joined us. Thank you, Dr. Kishore.
Thank you. Thank you, Sudhar.
Over to the organizers.
Thank you.
By this note, we would like to end this session for today. Thank you everyone for sharing your deep knowledge and experience on various topics with us. We will join tomorrow. Have a great evening.